Ladies and gentlemen, before the official opening of our strategic conference, The Value of Innovation, I have a question for a reward for you. If you look out of the window and I tell you it is November and you don't know where you are, in which city, would you know? You would, right? And this will be the case until March, but in between we will take pleasure from the events such as ours. This is our 11th strategic conference entitled The Value of Innovation. I bid a warm welcome to all of you today. This is a strategic conference that looks boldly and decisively into the future, to the future that creates benefits for the entire society on basis of digital and development breakthroughs. The International Forum of International Research and Development Pharmaceutical Conference, for our 11th year in a row, offers answers and insights into the future in the field of pharmacy and healthcare, which affects the quality of life of the entire society. This year, the conference focuses on value-based healthcare. Such care delivery puts the patients and their health at the center and aims to organize healthcare in such a way that we achieve the best treatment results for the patient in terms of the money invested. Experts in this field will discuss how to bridge the gap between the need for high-quality care delivery on the one hand and the available resources on the other. And of course, we never have enough money. Achieving high value for patients should become the overarching goal of all health innovations and care delivery. And this is also the desire of all of us here as a society. I believe that the first speaker also shares this desire and wish. I would like to invite now to the podium Yuri Stariha, Master of Science, Board President of the Forum of International Research and Development Pharmaceutical Companies. Please, the floor is yours. Can you hear me? Yes. Dear guests, welcome at our traditional strategic conference entitled The Value of Innovation. It is organized by the Forum of International Research and Development Pharmaceutical Companies. This is our 11th edition. Last year, we discussed the significance of digitization in healthcare. This is one of the basic foundations if we are to build sustainable value-based healthcare. The concept is being upgraded with our value-based healthcare. Maybe you're not so much familiar with the Slovenian term, but only the English term. Anyhow, it puts patients and their health status at the core of the system. And to the large extent, we improved health outcomes which are very relevant for patients. We are here today to discuss these issues with foreign and Slovenian experts. We will make an attempt to answer the question on how to bridge this gap between limited resources on the one hand and high-quality healthcare we all wish and strive for. We invited many foreign experts. We have been active in the field for years because this concept has been well known and relevant, well established in foreign countries compared to Slovenia. However, we do not sleep when it comes to this field. We invited many Slovenian experts because they also provided the guidelines and prepared the guidelines for value-based healthcare. You also received the booklet. I warmly recommend to look at the material because it is really excellent. Welcome again, and I would like to thank all of you who attended this conference here live, but also those who joined us remotely. I would like to thank all the participants and speakers, as well as the participants in the round table, for sharing their experience and insights. I am firmly convinced that the 11th edition of our strategic conference, The Value of Innovation, will significantly contribute to the dialogue of all healthcare stakeholders to develop our healthcare system further and to be sustainable and of high quality in the long run. Thank you very much. Today we have just mentioned and talked about the future, and if we add to it the word digitization, a couple of years ago we said that digitization is the thing of the future. However, we are now living this future because it represents our present day life. It is a basis for building better world, saving costs and valuable time. Some also save their time because they follow us via live stream. We have unimaginable seas of data and connections which are the key for taking decisive steps into the future aimed at a more holistic and more personalized treatment of each individual. At the same time, digitization is the foundation of networking of knowledge, research and findings that lead to the new breakthroughs also in medical area. This topic is also very close to the heart of next speaker, as her research interests include data technologies, big data, blockchain technology and medical informatics. With us is the State Secretary at the Government Office for Digital Transformation, Dr. Aida Kamišalić-Latifić. Please, the floor is yours. Dear organizers, speakers, participants of the conference, it gives me great pleasure that I can share some insights in the vision of the Government Office for Digital Transformation. In our service, we encourage the inclusion of digitization for the transparent operation of the system and organizing resources when introducing innovations and providing new solutions. It calls for optimization of processes at different stages. Slovenia supports digital transformation in the so-called European way. That is, we focus on humans and based on solidarity, cooperation and respecting sustainable development. The bedrock of our activities and the way how we formulate our policy is human-centered approach. The key pillar of digital transformation are cohesion, infrastructure, gradual approach, digital competence of all professional groups. This is the driving force to introduce systemic changes. We need to build such systems that would use the benefits of digitization with the purpose of supporting us when taking decisions. It is of key importance that the public sector starts using data for taking decisions, and also that we set up systemic measures to have accessibility, quality of services also when it comes to the healthcare sector. As the state, we have a clear vision of digital transformation of the society, public sector and public services, and also the society and local authorities. In addition to the basic foundations that I have mentioned, we need supportive ecosystem enabling mutual dialogue and a comprehensive approach when it comes to digital transformation. In this way, we will encourage development, build relationship towards innovation, and create a tool and environment for digital transformation. I would like to briefly present some of our important plans in this sphere. You probably know that we have adopted a national program to improve the adoption of artificial intelligence in Slovenia by 2025. Allow me to mention the strategic guideline, reference framework for introducing digitization in the public administration, society and private sector. It supports concrete measures to support research, innovation, the introduction of artificial intelligence systems throughout the life cycle of innovation. We have 6 priority areas: health industry 4.0, language technologies, sustainable food production, environment and spatial planning. This August, the government adopted the plan to develop gigabyte infrastructure by 2030. Our objectives are very ambitious. Among other things, by 2030, we want to provide for the coverage of all households with giga networks. Our service for digital transformation focuses on human-centric development. All digital services will be developed and centered towards users. When it comes to digitization of public services, our objective is that by 2030, All key public services will be made available online. All citizens will have access to their healthcare records. We work intensely to reinforce the cooperation of all stakeholders when it comes to preparing systemic solutions, and this goes for identification, planning of solutions, and designing the most appropriate approach in order to implement these solutions. If we are to have the mass use of such services, the basic precondition is to have uniform digital identification of users when using these services, which is why we have prepared user-friendly services, cross-border interoperability, uniform identification and entry, as well as user-friendly interfaces. In October, we were able to use the electronic ID with biometric data and also some tools for e-commerce. New ID enables us to have electronic signature, which is equivalent to blue ink signature. Next year, this ID card will be used in procedures for which we now have the healthcare insurance card. This will be now replaced. We also need to make sure that we have trustworthy data and services so that we have interoperability between institutions and cross-border. We need to have databases and standards for data processing and setting up of data room spaces. Of course, we cannot forget that those working in the public sector need to be digitally equipped and trained to use innovative methods. They need to know about the significance of data. Well-trained and motivated citizens are the key to innovative solutions. Without the investment in people, their retraining, we will have difficulties in coping with these challenges. The use of advanced technologies, methods and data will enable us to effectively manage and take decisions. Business processes, together with digitization, need to be optimized and included in the digital environment. As for legislation, in terms of substance, it needs to promote the use of digital services so that it doesn't stand in the way of progress when it comes to digital solutions. Digital technologies have a potential for promoting more inclusive and sustainable growth, encouraging innovation, creating efficiency and improving services. Slovenia has excellent IT experts, engineers and designers of solutions. We have a very stimulating environment for testing and validation. If you bring all this together with efficient communication, dialogue and sensitivity when it comes to introducing innovations in digital public services, we have all the ingredients for success. We have many ambitious objectives. I believe that we will be able, with the right approach and cooperation, to translate them into practice, and all stakeholders will be involved. Thank you very much. Thank you very much, Dr. Aida Kamišalić-Latifić. Unfortunately, she has to leave us because she has other obligations. Not far, she will have to go to the parliament. It is just across the road. I come from a village where digitization is not there. As you see, 1.0 megabyte is the internet speed, I have to say. However, today we speak about a completely different future. And from the village I come from, we also believe and support such development. And we will get to know our new friend. Those who haven't met her last year, you are probably wondering about her name. Medicine, on this part of the future, also receives from high-tech development achievements. We will get to know one of them later, when we step from the initial wishes into the shoes of real life. The Maribor University Medical Center started to introduce the robot called Frida into the clinical setting in May. Those who were here with us were able to know her then. Frida is the first humanoid robot in the world to be tested in a hospital setting and is intended to assist medical staff. Frida, now she's still resting, is involved in the work at two departments of the surgery clinic, namely the thoracic surgery department and the clinical department of abdominal and general surgery. She performs routine measurements, such as taking temperature and blood pressure, continuously monitors the patient's vitals, and then transmits the data to the doctor or nurse. The project of the humanoid robot for help in medicine is part of the international project Horizon 2020. It is led by Doctor of Electrical Engineering Isidor Mlakar from the Faculty of Electrical Engineering and Computer Science of the University of Maribor. I will soon greet him as he will join us. We will hear from him from Maribor live. Isidor, can you see us? I think I need to wave here so that you can see me, right? Yes, welcome. Greetings. If I conclude, the robot is being developed by the Faculty of Arts, with the local Faculty of Arts and the University Medical Center. Dr. Mlakar, you know Frida best. How well is she advancing months by months and weeks by weeks? Please, the floor is yours. Thank you very much. I hope that you can see my slides, my presentation in the whole. We started with our robot last year, and as of May, we have been introducing her in the hospital setting. Every solution also means that we present our robot in the actual setting. We have to cooperate with key holders, and they are part of our development. The question is, why robotization or humanoid robots in healthcare? We have been dealing with this question since the beginning. The idea behind this robot is to provide high-quality care to patients. This is value-based hair care, and we can start this at the hospital. This robot, with minimally invasive, human-resemblant care, can talk to humans. You monitor patients, help in the implementation of therapies, is enabling social engagement of patients. Last and not least, the robot can also motivate or even entertain patients so that they feel better. In this way, we enable artificial intelligence in medicine to capture additional information which is not gathered by staff. So we relieve the workload on the staff consequently. They can also simplify the work because they simplify routine tasks, they are engaged in stock monitoring, placing orders, they help in labs, and they can also help us with data input, what we will see later, so that we will have e-charts available. The purpose of our project is that staff are not involved in red tape so much, they can really focus on their patients. They can focus on more complex tasks without interruptions, they have a lot more time for the interaction with patients. And this is in fact the purpose of our robot, not to replace humans, but to relieve the workload, relieve the burden, which is why they can perform their basic mission and tasks. In the framework of the study, we also conducted a cross-sectional study. We compared how patients and also employees would respond to robots. As you see, about 470 employees were involved and 371 patients. We put some very simple questions to them. We verified how they see robots, whether they accept them or not. If I summarize, most patients agree or would agree or doesn't see any problems with when it comes to the communication with robots. And also employees, they are quite encouraged, but there is also some negative concept in the background because they fear that robots would make a mistake. And based on this, we included this in our co-creation. So how about artificial intelligence in hospitals? It is an imminent concept, and when used correctly, enables significantly better quality treatment and life after illness. Yet, there are some problems with digitization in practice. How to create e-therapy sheets, who will fill them out, how will they be involved, and how will we gather this data and persuade people to cooperate. The fact is, however, that in hospitals, humanoid robots can essentially simplify the integration of artificial intelligence in standard practice. As for the future, let me conclude. If you look at a robot, it is only a tool, it only helps. It doesn't take away from us anything, it won't replace humans. And better active involvement of all stakeholders, especially patients and the entire staff. By way of conclusion, we will demonstrate to you the progress from last year when it comes to our robot Frida. Thank you very much, Dr. Mlakar. Frida, hello. Hello to everyone. Thank you for inviting me today to your conference. I see that you are a bit different. Your voice is also different. It's true. I have a year of development and 4 months of induction in the hospital setting behind me. These are the results of hard work, a changed voice, and I can also adjust the speed. New ears so that I can direct my voice better, and a small box at the back on my head so that I can respond more quickly. Well, I'm also learning to be polite and how to correctly approach patients. Quite interesting, Frida. Tell me, why do you need all these things? What will you be doing by the patient's bedside? What kind of data will you gather, and to whom you will report this data? A very interesting question. Together with doctors, we finally completed my job description. I will have 3 tasks. First is to take the temperature regularly and read the vitals from the bedside devices. Another task would be to ask patients how they feel about the level of pain and the problems they encounter. Of course, all this with the help of standardized questionnaires. And my third task, to present this information together with the clinical picture to doctors during rounds. I will create an electronic chart for each patient, link it to the latest results and fill it with the data I collect and display it on the tablet on request. Frida, what kind of questions of patients are... Oh, Frida wants to say something. Yes, we are just discussing that maybe I should also try my hand at the admission and help with the medication dispensing, but we'll see about that. Frida takes some time to answer. She is smarter than us humans. But Frida, what kind of questions of our patients can you respond to? Can you tell them about the weather, what day is it, about the time of the rounds? So far, we agreed that I can communicate to patients advice that have been prepared by doctors, for example, to present the procedure. She's thinking, says the moderator, obviously, because Frida doesn't speak now. For example, what they can expect from these procedures, what are possible risks. and also about what follows after the procedure and what they should do at home. Of course, I will enable patients also to have internet access, to cheer them up slightly. And of course, if they want to know about the weather, I will be able to check this at the website. Well, we are in Ljubljana, and therefore I can definitely say that we will have fog tomorrow. Frida, I hear that you are learning to recognize and identify depression. This is a question that Dr. Mlakar. No, notice depression, but maybe notice some signs that show that there is a possibility of depression. I will listen and observe how the patient is responding when I talk to him. As for doctors, based on these characteristics, I will communicate why I took this decision when recognizing certain conditions such as depression. As for you, well, I'm still far from a verified opinion, so I prefer not to speculate at this stage. Thank you, Frida. It seems that I was a guinea pig for Dr. Mlakar. Thank you for inviting me. It was very nice to see you again. Well, next time, Frida, until next time, see you. Yes, I hope that we will see you quite soon. But not in the hospital. Bye. Bye, Frida. I think she deserves a round of applause, our Frida. In the center of work of our robot Frida, at her center, is also patient. Value-based healthcare means exactly this, because this means that we have to change our mentality first. As we saw, there is a lot of work ahead of us still, changing the vision of the healthcare system, because health has to be organized in such a way that we have the best healthcare outcomes relevant for patients. For most healthcare systems, unfortunately, we don't have this outcome-based approach. The measuring of health outcomes and transparent display of results enable comparability of providers with the aim to improve everything at the highest possible level. But now it's high time that value-based healthcare for patients and the entire society is presented by our keynote speaker this year, Nicola Beddington. Let me present her. From 2006 to 2019, she served as the first Secretary General of the European Patients Forum, where she remains as a special advisor. During her tenure, she helped build an organization that has become the leading voice for patients in Europe and which unites 75 umbrella member organizations. She led the European Patients Academy and Therapeutic Innovation. It is this academy that now provides education and training of patients about medicines. She also is co-chair and advisor for global healthcare, which also is based on values. 2 years ago, she co-founded the consulting company Millwater Partners, specializing in health, collaboration and sustainability. She's already building the future and her vision sees far ahead. Also today, our view and gaze will be extended into the future. Please, the floor is yours.
Thank you so much, and thank you for that very kind introduction. I'm delighted to be here in beautiful Ljubljana to talk about person-centered, value-based healthcare, achieving the outcomes that matter to patients, to systems, and to society. In my presentation, I'd like to look at defining value-based healthcare, why the shift is important, a couple of examples of implementation to date, but of course you'll get much more insight from both the Netherlands and Sweden later on in the meeting, to look at global and European initiatives advancing value-based healthcare that may also be interesting for you here in Slovenia, to explore a couple of critical success factors, examine why person-centred value-based healthcare matters to patients and how we might be able to blend the two concepts, person-centred healthcare and value-based healthcare, and a couple of recommendations from the patient's perspective in moving forward. Now, I know we have a very diverse audience. We have some real experts in value-based healthcare, and we also have some newcomers that are keen to learn more, and I'm hoping that this presentation will have something for all of you. So defining value-based healthcare, let's start first of all to define value. There's no single definition of value within value-based healthcare. The definition is actually subjective and differs between different stakeholders: patients, healthcare professionals, healthcare providers, payers, the regulators, policymakers, and industry. We can look at technical value, achieving the best outcomes with available resources. We can look at personal value, the appropriateness of treatment to achieve the goals of the individual. We can look at societal value, the contribution of healthcare per se to the social fabric, to social participation. And we can look at allocative value, equitable distribution of resources across different patient groups. And this was a subject for the expert panel on better ways of investing in health back in 2019, which produced the publication, The Value in Value-Based Healthcare. And I'll come back to this at the end of my presentation because the European Patients Forum was given the opportunity to input here, and this will give you a sense of the patient's perspective on the broad topic. So, value-based healthcare was actually coined initially by Michael Porter and Elizabeth Teisberg in their book Redefining Healthcare back in 2006, essentially looking at outcomes that matter to patients divided by the cost to achieve these outcomes. This is the value ratio. The numerator, outcomes, designate condition-specific results like increased mobility, enhanced appetite, quality of life. And the denominator, cost, applies to the total spending for the full cycle of care. And if the outcomes aren't actually improved, that means low value. So value-based healthcare broadly has come to be known as healthcare systems looking at actually measuring outcomes rather than looking at volume. More recent work has actually moved towards how we can engage patients at macro, meso, and micro level in terms of the move towards person-centred value-based healthcare. So the overall approach, this is a strategic framework, again, developed by Elizabeth Teisberg and colleagues, that gives you a sense of the different strategic levels. Understanding shared health needs of patients, first of all, designing solutions to improve health outcomes, integrating learning teams, measuring the health outcomes and the costs, and expanding partnerships. Another strategic framework looking at value transformation in healthcare picks up on 6 broad strategic elements: organising into integrated practice units, measuring outcome and cost for every patient, moving towards bundled payments for conditions. A bundled payment is a single payment for an episode that may involve different doctors and different processes, integrating multi-site care delivery systems and expanding geographic reach, underpinned, of course, by an integrated information technology platform. An important aspect of value-based healthcare is the monetary opportunity costs of the entire case process along the patient journey. And switching focus to health outcomes and care processes means reduced practice variation, increased quality of healthcare, and improved cost effectiveness. But why the shift towards value-based healthcare, why is it so important? First of all, we know that healthcare systems across the globe are unsustainable. Health inequities, even within countries, are increasing. Yet more than 25% of healthcare expenditure is waste. And this was recorded by OECD back in 2017. We have an aging population with increased comorbidities. In 2021, 20.8% of the EU population was aged 65 and over, and this is clearly set to rise towards 2050. We live in a very uncertain world. The European Health Policy Forum, Gastein, in autumn, referred to a perma-crisis. We have, of course, COVID. We have the current pandemic that we're emerging slowly from, but the perspective of future pandemics. We have conflict, the war in Ukraine, and conflict in other parts of the world. We have an energy crisis, and in many parts of the world, in many countries, also a major cost of living crisis. And we have the spectre of climate change, and of course everybody is understanding increasingly the links between climate change and health. So there is an urgent need to move towards health systems that can deliver with and for patients and people equitably, respond to their goals, but also as sustainable long-term. In my view, I feel that there are a number of tailwinds in our favour. We've already heard about the importance, the strength of structured, systematic digital transformation and responsible health data sharing for smart decision-making. And this was crystallised and indeed accelerated during COVID. There's a shift towards prevention, for example, from cardiovascular diseases to cardiovascular health. Earlier this year, the very first action plan, national action plan on cardiovascular health was published in Spain, for example. And there's also a move towards personalised healthcare. And again, we heard about this from some of our earlier speakers, looking at humanising healthcare, the human factor, but also moving towards genomics, precision medicine, from testing to targeted treatments. Value-based healthcare brings benefits for different stakeholders with skin in the game. And very briefly, one could go into a huge amount of detail here, but just to give you an overview, for patients, it means lower costs when there are co-payments, but also better outcomes, which means obviously they can participate more effectively in family life, in community, in employment potentially, and in society. For providers, it means higher patient satisfaction rates and better care efficiencies. And for healthcare professionals, it actually means doing the job that they intended to do when they joined the profession, when they followed that vocation. For payers, it means stronger cost controls and risk management. For suppliers, it means alignment of prices with patient outcomes rather than purely volume. And for society, it means reduced healthcare spending and better overall health for populations. I want to home in on implementation, take the example of NHS Wales. Several years ago, NHS Wales began applying outcome measurement to define value and make some investment decisions. And based on patient reports, only 19% of cataract surgeries did not improve visual disability. In 2017, in Wales, teams developed standardised PROMs, patient-reported outcome measures, for 31 care pathways, with questionnaires in both English and a validated translation into Welsh. And this was used strategically by NHS and clinicians for triage and optimal care pathways for each patient. Fast forward to 2022, and we have the Welsh Value in Health Centre with a robust strategy up until the end of 2024, enabling a whole systems approach. The vision is to achieve world-leading health outcomes for the people of Wales in a financially sustainable way. The mission is to provide leadership, support, expertise, and strategic direction right across the NHS Wales to achieve that vision. And the goal is really to embed a value-based approach at every stage of the healthcare pathway, building on good examples and learnings from different teams across Wales. There are 6 areas of focus that are obviously interlinked. First, person-centred care. Secondly, digital health. Again, familiar themes are coming up. Implementation across the entire NHS in Wales. A commitment to communication, engagement, and education. An eye on impact, the so what factor, delivering value. And sixthly, really important, collaborations with research, industry, and strategic partnerships. And I've given some examples of the strategic partnerships that the centre actually has. And it's really hub and spoke and demonstrates that one individual organisation or structure cannot deliver value-based healthcare alone. The centre is working with Digital Health and Care Wales, financial delivery units, NHS Trust and boards to build in accountability, Value-Based Health and Care Academy to get that education piece moving, and also the National Data Resource. So multifaceted, and I think that's an important point to remember, and has also been very much reflected in your guidelines. And in fact, Wales and Sweden and Netherlands, that we'll hear about further down the line, contributed towards implementing value-based healthcare in Europe, a handbook for pioneers, which was supported by EIT Health, and I know has been a source of inspiration for your guidelines as well. Moving to a different part of the world, and again, a similar sort of approach. In Australia, the Australian Centre for Value-Based Healthcare, established by the Australian Healthcare and Hospitals Association. The vision is a healthy Australia supported by the best possible healthcare system. And the emphasis is healthcare is funded and delivered with a prime focus on outcomes achieved at an affordable cost for patients and the system. Overall goals: increasing knowledge and understanding about value-based healthcare, building the skills, the competence, the capacity to actually implement the care, influencing public policy to enable the transition to value-based healthcare, to have that positive policy landscape in place, to curate and share best practice examples, theory and research, and to be a thought leadership organisation not only in Australia but internationally. And this brings me to a number of key players at global and European level advancing value-based healthcare. Of course, there's ICHOM, the International Consortium of Health Outcome Measures, looking at standardised sets of patient-reported outcome measures in different disease areas, also now looking at comorbidities and looking at how take-up could be advanced across the globe. The World Economic Forum in 2019 was instrumental in setting up the Global Coalition for Value in Healthcare, a public-private partnership looking at a really constructive dialogue at global level, but also building a repository of resources from across the globe to move the needle on value-based healthcare, and the Global Centre for Person-Centred Value-Based Healthcare that's really looking at personal preferences, personal goals, and measuring these carefully in specific data sets, but also keeping an eye on equity in population health. And I'll talk about that a little bit later on in my presentation. The HTO project is an innovative medicines initiative, again, a public-private partnership that's focusing on a health outcomes observatory, or rather 6 health outcome observatories across the European Union, that's focusing very much on data governance, data excellence, data infrastructure, in order to actually bring together and look and study patient experience and patient outcomes. And this is a unique initiative that will help to support all of the efforts around value-based healthcare in those countries. OECD launched an initiative called Paris a few years ago, 5 years ago. It's headquartered in Paris, so it was quite suitable. And we're looking here at patient-reported indicator surveys in order to contribute to the conversation that is had between policymakers, healthcare providers, and patients in terms of performance, in terms of measurement, particularly in the primary healthcare setting. And another alliance, the European Alliance for Value in Healthcare, again, a public-private, multi-stakeholder collaboration, looking at training, looking at capacity building, looking at pulling together relevant resources around implementation, but also some conceptual thinking and theory around value-based healthcare. So there's a lot happening out there at different levels. Coordination and coherence is perhaps a question here, but there's certainly a multitude of really valuable state-of-the-art materials to look at. Based on some of that, what might be the critical success factors for value-based healthcare? Clearly, strong and supportive leadership at every level, at health systems level, at political level, in terms of healthcare provider level, but also even between patients and their trusted healthcare professionals and shared decision-making. That leadership is critical. A change management mindset and long-term ambition. This isn't for the short haul. A team dynamic and intrinsic motivation, collectively a willingness to unite behind person-centered value-based healthcare. A trusted yet accountable environment and commitment to learning, a learning cycle. Digital transformation, of course, including electronic health records that patients can access, but also contribute their own data to. And digital health literacy on the part of patients, but also on the part of healthcare professionals. We heard about interoperability during the earlier intervention, the importance of moving, not getting there immediately, but moving towards interoperability of systems to optimize robust data, clinical and financial data, of course, but also social, environmental, and behavioral data, thinking about the thrust towards prevention and social determinants of health. A commitment to patient empowerment and patient engagement. And again, I'll come back to that a little later on. Embracing complexity, valuing an iterative approach to systems change, and also transparency, internal and external, on successes and failures. And as I've alluded to a little earlier in my presentation, an authentic multi-stakeholder cooperation and true partnership. This isn't exhaustive, but these are some of the concepts that have kept coming back time and time and time in the literature. So why does person-centered value-based healthcare matter to patients? The implementation of value-based healthcare focuses primarily on standardization of outcome data, which could risk jeopardizing the focus on the patient. But person-centered healthcare actually puts the patient at the center of healthcare, but doesn't always stress measurement and improvement. Health equity means all health systems have finite resources which must be allocated to different health conditions and different population groups fairly. A person-centered value-based healthcare framework can bring these different concepts together, and this is the premise of the Global Centre for Person-Centered Value-Based Healthcare that is overseen by SPRINC, an organisation in the UK. Person-centered value-based healthcare is a framework that prioritises a focus on what matters to the individual from the perspective of their goals and preferences. And the measurement system in person-centered value-based healthcare looks at both individual level data and aggregated data reflecting what matters to individual patients. It prioritises person-centered design of services and pathways to ensure that they really respond to the needs of local populations. Person-centered value-based healthcare empowers professionals to do what they are trained to do and what they want to do, to work with patients to co-produce care that meets their goals and preferences as individual people. So, by and large, person-centered value-based healthcare will help to address not only healthcare system sustainability, but also the needs of patients in an individual context, but also at population level. And the evidence is there that it actually leads to prudent use of healthcare, so not more healthcare, but actually less. Looking now at the broader patient's perspective and coming back to the expert panel and the discussion around the value in value-based healthcare, the European Patients Forum had the opportunity to input, and I think this captures nicely what the community is thinking as we move forward on value-based care, the community as a collective, I'm thinking. The importance of co-creating with patients and their communities and adopt a framework on meaningful patient and public involvement in health systems and services design and strengthening. Developing together with patient organisations, the EU member states and stakeholders, a comprehensive strategy to really move on implementing empowering practices and person-centred care. To ensure better transparency of clinical research and data, effectively communicated to all audiences using layperson summaries, etc., to support fully informed shared decision-making between patients and clinicians. To ensure appropriate involvement of patients in the creation of patient-defined outcome measures and experience measures, moving beyond perhaps PROMs and PREMs that reflect truly patient priorities and strategies to implement these in improving health systems. Exploring ways of encouraging research and innovation that meets patients' and society's needs while ensuring solidarity and equity, including public-private partnerships with the involvement of patients. Embedding meaningful patient engagement in the life cycle of medicines and technology, spanning research prioritization to really understand what the unmet medical needs are, clinical trial design, early dialogue between industry, patients, regulators, and health technology assessment agencies to really work out together what the evidence requirements are further down the line. Moving along that cycle, thinking about pharmacovigilance, real-world data, real-world evidence collection, and a recognition that at times disinvestment will be important, with the overarching objective of ensuring innovation reflects the unmet needs and goals of patients, but also leads to better outcomes. Involving patients in the training and continuous professional development of all stakeholders involved in value-based healthcare and resource allocation, again to understand that profound understanding of what really matters to patients. And finally, promoting effective patient and public engagement and dialogue about societal priorities, which should include sustainable investment in health and recognising patient organisations having a seat at the table to be involved in some of those very difficult discussions and dialogue. So a few concluding thoughts then. Value-based healthcare aims to drive care systems towards enhanced patient outcomes at lower cost. It covers or can cover the entire spectrum of healthcare: prevention, primary, secondary and tertiary care. The values embody the human element of healthcare, which is why a person-centred value-based approach is so critical. Moving from a fee-for-service to a fee-for-value is challenging. It will take time. In certain settings, it's more difficult and complex than people originally envisaged, but it's seen and recognised as the best methodology, but tenacity is needed. We need coherence and coordination across stakeholders. Efforts are needed not to duplicate or get into any level of competition, but really complement initiatives at global, European and national level and really create those synergies and that magic to move forward. And as we see the emergence of the European Health Union, there's an increasingly enabling European policy environment. We have the European Health Data Space, for example. We have the Beating Cancer Plan. We have a new thrust towards addressing non-communicable diseases with the Healthier Together initiative. And we also have really important funding streams, the EU for Health Programme, Horizon, which was mentioned earlier. We have the Innovative Health Initiative, which is the successor to the Innovative Medicines Initiative, and importantly, is not only focusing on therapeutic innovation, but is also looking at technological, digital, social and systems innovation. And we also have the Recovery and Resilience Facility at national level that is also looking at building back better, looking at innovation and looking at sustainability. So my last slide is actually a number of references and hopefully useful resources that I've referred to in the course of my presentation. As I say, I hope that you've each taken something from the presentation. My excuses to the experts in the room, but hopefully you've had additional insight about that very, very important patient perspective. Thank you very much for listening.
Thank you very much. Hvala lepa. Dobili smo en pogled v prihodnost in pogled, kje se ta prihodnost že izvaja in že dogaja in željo, da si jo želimo, samo so vsi trije možje decembra malo premalo.
All three men coming in December are not enough. We will probably have to write a letter to some other people and authorities. Anyhow, this is the healthcare model of today, operates on a fee-for-service basis, while the value-based model of healthcare, as we have already heard today, attempts to link quality and value to the resources invested. But the side effects are also not negligible. In addition to better results for patients, greater transparency and lower treatment costs, there is also the systematic development of indications for measuring outcomes by individual conditions, measuring different conditions. Currently, several indicators have been developed in the world for 42 medical conditions such as autism, COVID-19, lung cancer, personality disorders, but really everything starts, and as Mrs. Bedlington has mentioned, on trust and in the first steps of introducing our model. It's now time to learn from practice how it was introduced in the Netherlands, and with this we also set a vision for the future in Slovenia. With us is Peter de Bay, Managing Director at the Dutch hospital group called Santon. He is responsible for the implementation of Santon's strategy through joint programs in 7 member hospitals. Santon's guiding principle is value-based healthcare, which de Bay is passionate about. Mr. Peter de Bay.
The floor is yours, but I will say the Zoom is yours.
Thank you very much for having me. I will share my screen right now. Yeah, so my name is Peter de Bay. Indeed, I'm the Managing Director of the Santion Hospital Group. And we have decided a number of years ago that value-based healthcare is our guiding principle within our hospital group. And what I'd like to do today is give you a brief introduction to Santion and then talk about our approach to value-based healthcare, give you some concrete examples and some lessons learned. So Santion is a learning system, as we call it, of 7 acute and chronic care hospitals with national coverage in the Netherlands. We are the largest provider of hospital services in the country when we add it all up. We have over 35,000 employees, over 2,000 physicians, 10,000 nurses, and a revenue of a little bit over 3 billion euros. We are not one group in terms of from a legal perspective. We are 7 separate hospitals, but we have very close collaboration. And we decided about 10 years ago that value-based healthcare is our guiding principle, and we defined 5 underlying ambitions. And these ambitions are that patients are actively involved in their treatment choices, professionals work closely together, so think about our physicians, our nursing staff, our management, the leadership, they all work very closely together in a network. We share forces in innovation and research, and we in particular have the mission to make the quality of care that we provide transparent, both to our care professionals as well as to our patients. And we feel a obligation to keep care affordable and in particular accessible. So that's a really important part for us of the value-based healthcare equation. So patient value, and I'm sure you heard it before, this is Porter's formula, and I had the pleasure of working with Professor Michael Porter about 10 years ago when I joined ICHOM. ICHOM is the International Consortium for Health Outcomes Measurement. And at Santion, we use this value equation basically every single day in in determining whether we are actually able to increase value for our patients. So it's a very simple formula, but as you probably are all aware, it's not so easy to implement. But I think it's a very important formula or equation for everybody in our organization to be knowledgeable about. And the way that we can increase patient value is either by increasing health outcomes at the same costs, by achieving the same health outcomes, but at lower costs, or ideally improve outcomes while lowering costs at the same time. That's the ideal way, obviously, of improving value. And in order to get there, at Santion, we defined 5 strategic priorities for our collaboration. And we see ourselves as a accelerator of innovation. And we do this through these 5 priorities. The first one is our Better Together program, as we call it. And this is the one that I will explore a little bit more later on in this talk. We run improvement cycles now for 16 medical conditions in this Better Together program. The second one is that we are building a learning organization with talented professionals. And that means that we have training modules for our physicians, for our nurses, to really understand what it means to work in a value-driven organization. And also we share forces here on innovation and research. Then we build on a sustainable business model. I think the previous speaker also talked about how we want to move from fee-for-service to value-based procurement models and value-based contracting models. So on both these sides, both on the contracting with our payers, which in the Netherlands are health insurance companies, as well as with our suppliers, we are trying to move to more sustainable business models that will continuously drive the improvement program that we have. This is the part that is not easy, and I think in the Netherlands, this is the part that goes at this point actually slowest. And then we decided that virtual or digital care, e-health solutions, remote patient monitoring is one of the ways that we believe we can really make a leap forward in being able to provide better value, more value, better care at lower cost to our patient. So this is why we made this a separate strategic priority, is to really push forward on the digital care agenda. So we are building a platform together with our 7 hospitals to be able to provide, for example, remote patient monitoring services at a national level. And then finally, the 5th priority is our HIPS platform. It's called the Health Intelligence Platform Santion, which is on data and analytics. And it provides a data platform and analytics capabilities, basically to support all the other priorities. So this is why you see it as a circle around everything else. I think it's important to realize that these are the 5 strategic priorities, and I will zoom in mostly now on the Better Together program. And in this program, we run a standardized improvement cycle across our 7 hospitals, which means that we always start with a team, defining a team, a multidisciplinary team, and the process. We set up a scorecard. I'll talk a bit more about that, and an improvement plan. And then we start collecting data. We look for differences. We benchmark across the hospitals. We analyze those differences and identify improvement opportunities and implement those improvements. So this is basically your typical PDCI cycle. And you know, at the same time, it's about continuous feedback and learning. And the way that we set this program up, it's quite a strict format, is we run 2 of these cycles annually, so 6 months each. We always do this around a patient group, which I think is very much at the core of the value-based healthcare theory. So we don't do it around a medical procedure or around a capacity like the ICU or the operating room, also not around a specialty, but really around a patient group, which makes it, in almost all cases, very multidisciplinary. And we aim for full transparency on patient outcomes, cost, and processes. We currently do this now for 16 different patient groups, and here you see the main oncological treatments that we do in our hospitals. You see a number of chronic conditions, including COVID-19, also patient groups like the frail elderly, and we have a procedure where we are still expanding this. So every year we add about 2 or 3 of these patient groups, and we have a good selection process of how to determine what the next of these processes is. You see here on the right, you see the map again of the 7 hospitals, and you see that there's an improvement cycle within each of the hospitals, as well as a combined improvement cycle across all of the hospitals. And as I said, for each of those patient groups, we install a multidisciplinary improvement team in each hospital involving patients. So typically, this is an example for breast cancer. There will be a surgeon, a pathologist, radiotherapist, oncologist, plastic surgeon, nurse practitioner, radiologist, nurses, pharmacist involved, and it will be supported by a project leader and a data analyst, and 1 or 2 patients join the group. And the patient participation, I believe, is very important to make sure that in those improvement teams, the conversation is actually really about what matters most to patients, instead of what matters most to the surgeons, for example, right? More the medical perspective, because we really try to shift the conversation towards what matters most from a patient perspective. I think that's a really important part of the value-based healthcare thinking. It is not just a way of thinking in terms of, all very at a qualitative level. We believe that the right approach is to make it very data-driven. It's both data-driven and patient-centered care. And therefore, we've been building on our data platform, which I briefly mentioned at the beginning when I talked about our 5 strategic priorities. And we are putting a lot of effort in data quality and in data standardization. These are, I believe, really important things to work on in order to be able to really do this well. And what we also learned over the last years is that transparency is a really important part of this. And it's not always easy. So the way that we set it up in our program is that each of those patient groups and the multidisciplinary teams, they go through different phases. So we start in a phase that we call internal transparency. So that means that we are transparent across our hospitals and in between the hospitals, but not necessarily to the outside world yet. It means that we work on creating a trusted environment to have these open discussions. We also work on the reliability of the data. What we always see is that in the first times that we run our benchmarks, for example, that actually the data is not good enough or strong enough always to answer the questions being asked or to provide the right insights. So we really have to work through a couple of cycles to improve the quality of the data and the comparability of the data. But after a few cycles, it dramatically improves. And we already have then the opportunity in this phase to implement obvious improvement opportunities. So this is what we call the internal transparency phase. But then we push the teams within typically about 1.5 or 2 years to move towards external transparency, which means that we create publications and we provide quality information on our websites across the 7 hospitals, so that the results and the outcomes become available for everyone. Because we believe that that is also a really important part of value-based healthcare, is that we are transparent about the results that we achieve within our hospitals for our patients. It also provides us the opportunity to deepen the analysis towards more sophisticated actions, and also to get to value-based contracting models with the insurance companies. And then finally, we move to a phase that we call the Santillon standard of care, where we really fully embed the methodology, the process of continuous improvement. We can do more in innovation and research, and also we include shared decision making as one of our key goals, where we discuss the expected outcomes with patients and enable better decision making. Really, sort of, in the conversation between the medical professional and the patient. So these are the phases that we learned that we have to go through in order to get closer and closer to the standard of care, which is really something that we haven't achieved in all our patient groups yet, in all our medical conditions yet, but that we are aiming forward to and moving towards. I think the outcome transparency, just to highlight it a little bit more, already in 2013, we started our first publications. We published our first publications, which are partly scientific publications, but in journals, but they're also really popular publications, so to say. So these are aimed at care professionals or at patients to provide to share the lessons learned that we have around breast cancer care, around stroke care, around hip osteoarthritis. These are a couple of the examples. Then in 2019, we started to also share infographics online on Santillon.nl. Everybody can actually visit the website if you want, and you can see some of these examples. And there we try to share in a graphic way, easily understandable, some insights on the population that we treat, but also, and you see that in the small graphs in the middle, also the differences actually between our hospitals. So we are transparent about how the one hospital achieves, which outcomes one hospital achieves also versus the other. And we believe this is important also to keep this improvement cycle going. And then in 2020, you see that we started with our first decision support instruments, where we really use the outcome data that we collect in the improvement cycle to also use this as crucial information in the conversation between doctor and patient to get to better decision making that fits the preferences of the individual patient. So the improvement cycle, maybe just to highlight it a little bit more, the improvement cycle is really focused on a sort of aggregated patient group level, while the decision support instruments are really aimed at improving the decision making for each individual patient. So on both of these levels, we try to use roughly the same data that we collect in our data standards. So here I have one example on so what a standardized scorecard looks like. And this is an example for breast cancer. So here you see that we collect a limited number of outcomes. You see things like 5-year survival, non-surgical complications, a number of patient-reported outcomes, quality of life, specific conditions resulting from the treatment. We collect a number of cost indicators, and I call them cost indicators because they're not necessarily measured in euros. We try to measure them in capacity use. So, for example, the number of treatment days or average length of stay, the operating time per patient, the percentage of outpatient care for breast-saving treatment, for example, the number of outpatient visits. And then we have a number of process metrics that are typically the timeline. So it's, for example, the number of days from referral to the first outpatient visit. And I think this is actually also a really important part of it. When I joined some of the early groups at Santillon, which were actually around breast cancer, one of the patients in the room said, for me, the most intense part of this whole patient journey was basically at the beginning, when I was very insecure, when it was completely unclear what was going on with me, and what treatment plan we were going to follow. And this is why we included the number of days from referral and the first outpatient visit to the treatment plan. And because these patients said, like, this was the time that was most impactful for me. And we really didn't have a clue. And we saw when we started measuring this, that there were very big differences between our hospitals. So what we do is this standardized scorecard with these 3 categories. We have one of those for each of our medical conditions, so currently 16. We use them in each of our 7 hospitals, and we score them across these 7 hospitals. And what do you see then if you look at the data? For example, we see that the 5-year survival for breast cancer patient is very similar across all our hospitals, fortunately, right? I think all our hospitals provide high quality care. So we see that there's only small differences in that metric. But what we also see is that when we look at costs, for example, or the use of capacity, that there are significant differences. So for example, the diagnostic cost could range from 400 to 900 euro per patient on average, or certain medication cost could range also a factor 2 to 3 between the hospitals. So there's quite some practice variation that we see when we really start measuring this. And we also saw that on the outcome side, that there was variation in other outcomes than survival. For example, the differences in reoperation rates after a positive margin, ranging from 3 to 11% across the hospitals. And here you see this last example, the 3 to 11%. You can see that here in this graph in the red. So you see that the Martini Hospital, which is the hospital in the north of the country, achieved a 3% percentage of repeat operation, while the CWZ, which is in the east of the country, had 11%. And I think what is quite what I'm really proud of is that we are willing to show this. What we can also see is that after 2 cycles, so this was about a year later, we already were able at the CWZ to manage it down to actually 4%, so huge improvement. And we track this over time, and this is actually from a couple of years ago, and we are still tracking this. But you have to understand then, so the discussion is, okay, this is data, right? First of all, do we trust the data, right? But then secondly, if we trust the data, what can we actually do about it? And that's the conversation that the medical professionals have. And they came up with a couple of things. For example, on the technical side, started using ultrasound during operations if the tumor was visible on ultrasound, and that was adopted from other St. John hospitals in the CWZ. But also awareness, just that every member of the team was made aware of this higher reoperation rate in this particular hospital makes a huge difference. And now there's a continuous focus on this effort, and it became part of the multidisciplinary team discussion on in individual patients. And then finally, also there was work to be done on standardization in the data itself, because there turns out to be a difference in the interpretation of margins by pathologists across the hospitals. So that's another type of intervention that could be done. So this just give you an idea of what kind of interventions, what kind of insights can come from measuring outcomes and really comparing across different care providers. A second example is hip osteoarthritis. And here you see another scorecard. You see different outcomes and different costs, but the same structure. Some examples here is that we saw that we actually see very few complications during hospital admissions after the primary hip operation. But we also saw that, and we also saw that 98% have not undergone a revision surgery within 2 years. But we did want to create more transparency about those revisions. And we also saw that it was actually possible to achieve a decrease of 17% in the average hospital length of stay after a primary total hip operation through rapid recovery programs that were already in place in 1 or 2 of our hospitals, but we have now scaled up to all the other hospitals as well. And these kind of interventions that are typically done in 1 or 2 hospitals, at least that's the same, that's the case in the Netherlands, that we see there's quite some innovation at the local level, but quite often these are not scaled up to other hospitals, is something that we see, where we see a lot of potential every day in the way that we run this program. And one other example was that in the OLVG, which is the hospital in Amsterdam, that they could reduce the number of lifestyle rules for these active hip patients. It turned out that when comparing the information that went to these patients, they were actually relying on outdated advice to these patients. It wasn't up to the latest guidelines anymore, which had actually a huge impact on patients' quality of life, because in this particular case, they had to stay, I believe, in bed for a number of weeks, while that actually wasn't the latest insight anymore. So you see that sometimes also comparing those kind of things can actually have a huge impact on the patient perspective, from a patient perspective. And then finally, a third example is how we use outcome transparency also for shared decision making. I already mentioned it in the beginning of my talk. And we have a number of aims there. And one is that we use the available real-world outcome data from our health intelligence platform to extract new and valuable insights in patient-relevant treatment of these outcomes, and develop and implement an effective approach for the use of outcome data in shared decision-making, inform patients about outcomes that they can expect at different care providers, and also for different treatment options. And then we also gain insights into the degree to which shared decision-making actually leads to different treatment choices and increased patient satisfaction. So we also run a research program underlying this. And here you see a number of shared decision tools that we created. Here on the left on stroke, and this was really focused on stroke patients in our hospitals, and then increase the number of times when shared decision-making really leads to a different choice of where the patient goes after being dismissed at the hospital. What we originally saw is that very often that is currently determined by the neurologist, the treating neurologist, while actually patients don't necessarily end up in a situation where they should be, for example, based on their home situation. And by building this tool, we have now a much better process of also taking the patient perspective into account when making this decision together with the patient. And the same example in the top right on breast cancer, and this is about after the treatment is done, basically, how often in the next 5 or 10 years do you actually need a checkup in the hospital? And that is something where for different risk categories, you can make different choices together with the patient. So we are also implementing that. And finally, on the bottom, you see an example from chronic kidney failure, where it is really about the most important treatment choices. For example, whether someone will start dialysis or not. And using the outcome data across all our patients, across all our hospitals, to make a better decision process there, because this can really depend on individual patient preferences. So I will wrap up with the lessons that we learned during this process. And there's more lessons, but I think these are some of the most important ones that we learned over the last 10 years or so within the Santillon Hospital Group. And I think they actually have quite some similarities compared to the previous speaker. So it's really important to create a common understanding of value. What do we mean by value and how do we measure it? And I believe that this is should be very strongly based on the value-based healthcare theory, and in particular on measuring actual outcomes instead of just the medical processes, for example. So really a focus on patient outcomes and measure it using data standards. Secondly, I think to make this a real success in a provider organization, I'm really talking from the hospital, the provider perspective, it is important to ensure long-term C-suite commitment, because this does not pay off immediately. It is a cultural change. It is a long-term program. And it's not necessarily the case that each intervention will immediately result in a better financial position as well. But we believe that by having this continuous improvement cycle, that in the end, it will also financially pay off for our hospitals. I believe it's important to start small, be pragmatic, and then create a snowball effect. So don't try to do everything at once and build a huge data platform, etc. I think you need to start small and see the results, and then keep the pace also towards transparency that I talked about earlier. Build a safe learning environment. This is about learning, not judging. And I showed you that we are transparent to the outside world, but also inside transparent internally. And I think this is really, really important to continuously focus on. This is not about judging the ones that are perhaps at this particular situation sort of lowest in rank. We usually also don't rank. We just show the results and then try to have this conversation started of what can we learn from each other? What can we improve? And also get rid of the not invented here syndrome. I think this is, at least in the Dutch healthcare system, a big problem, is that everybody wants to reinvent everything for themselves. And what we really try to do is to get rid of that and really, be open to copy from others. Then I think it's also really important to have medical professionals take the lead, but we also have to provide them with the right level of support. So in each of those improvement cycles and improvement teams that I mentioned, for example, on the breast cancer one, it's the breast cancer surgeon that is in charge. They're in the lead. They determine what does our improvement agenda look like, but they are supported by project leaders and by data analysts, because we cannot expect them. I mean, very often these meetings are already at night. It's like after a long day of surgery. So it needs to be very well prepared. And that's the level of support that we provide them from an organizational perspective. Then it is about the patient, but also with the patient. So we really try to actively involve patients, as I showed earlier, patients within these improvement teams, and also really involve them, for example, in building those decision support instruments. And then I think when getting more advanced, number of years into the journey, then innovate using new data techniques, these decision support tools, a platform strategy. I think these are then the steps after sort of starting small that you can build towards those kind of more advanced uses of real world outcome data. And I think finally, it is hard work. We've been working on this for the last 10 plus years. Data-driven, value-based decision-making, it takes time to learn. But I believe, and I think we see that within the Santillon Group, that it's absolutely worth it. So with that, I will stop sharing my screen, and perhaps we can open up for some questions or some interaction.
Mr. Debay, thank you for sharing with us your experiences, and I am sure when Slovenia will be ready to push forward to value-based healthcare, we will hear again. We'll have questions after the next speaker, and you're more than welcome to stay with us.
Perfect. Thank you.
Thank you. Goodbye to
Thanks
Netherlands.
for having me.
As we have heard already on many occasions today, a prerequisite for the introduction of the value-based healthcare concept into the system is first the willingness of stakeholders to cooperate and make changes. We will now see in detail what are the opportunities but also the obstacles standing in the way. With us is Secretary General of the Stockholm Healthcare Foundation, Mr. Hans Windberg. Hello. He works as an expert advisor in Sweden, but also elsewhere in Europe. He is now part of the leading healthcare foundation, which is also the academic trust think tank working with applied research around policy, governance, leadership, and organization in the healthcare and care sectors. The aim is to gather all relevant stakeholders to explore value creation in combination. And now, about details, about opportunities, but also barriers in the continuation. I believe that he will open new horizons for us, and probably we will gather more courage to take the first steps along this path.
Thank you very much for that kind introduction, I think. My Slovenian is not so good. How's your Swedish? Should I take it in Swedish? So thank you. It's a privilege and honor to be here, and it's an honor to be in place and meet with people and visit Slovenia. It's my first time. It's not my first time interacting with Slovenia, but it's my first time here. So I'm very, very happy that you invited me. I'm going to talk a bit about opportunities and hurdles of outcomes-based healthcare, and a short introduction, I think, is needed. So the leading healthcare foundation was founded by the Stockholm School of Economics in 2010. After I had worked within executive education for almost 15 years, mostly within healthcare. Worked with health economics and the spread of the techniques of health economics in the 90s in Sweden. And then also with trying to create the systems and a leadership perspective into how to change and transform this sector, because it is a very complex sector. And as I believe, from what I understood that you said, Martina, the idea from the beginning was that we worked with different stakeholders, one or perhaps two at the time. Could be like the pharmaceutical industry and the pharma, which then was run by the state in Sweden, that they actually had common because we're doing drugs both, perhaps we should talk a bit. But you never had the payers, you didn't have the politicians, you didn't have the professional groups. So either they were pharmacists and they hate doctors, or you had doctors and they hate pharmacists, or not hate, but they don't want them to intrude because of the not invented here syndrome. So what I saw coming from business administration and also being interested in modern developing market theories, I saw that, well, if you take the patient's view or the citizen's view, the only thing that matters is what kind of care you get. And you don't know and you don't really care about the multitude of stakeholders that was involved, from researching a new drug, developing a new method, administering some innovative surgical techniques and everything else. You don't want to bother about that. You want to bother with, what do I have to do, what can you do, and how can I be healthy again? Because I don't want to die. And that sort of unites all of us human beings into one. So we thought, well, why not take the system from above? And we gather all those stakeholders and actors and put them in the same room and say that, okay, fight from the standpoint you have. Don't neglect your own interests, but recognize that we all have different stakes and interests in this room. And if we can talk about that in a transparent and guided way, we can actually come up with new questions that can provide us with better solutions. So that's what we have done. So now over to value-based healthcare. In 2007, I think, was the first time that Michael Porter was invited to Sweden to talk. And we had a big movement. And that's because Porter, together with some people from BCG and from Karolinska, had identified Sweden as the first place where you could test the models. And that's because since the 70s, we had quality registers. We have 120, 30, something like that. 80 of them are really working well within all these different groups that we saw from Santian. And so the assumption was that the data is there. So we can actually use this because we have some measurements and we can use that to improve the system. We just have to add the costs. So I think that this is one of the founding cornerstones of measuring outcomes in healthcare. It's data. And data is rather hard. In Sweden, we have electronic health records since the 80s or something like that. We were quite fast in the beginning, quite slow when it comes to use more modern techniques today, like more database thinking and report thinking. And this turned out to be a hurdle, that we didn't have the IT systems in place, because data collection takes an awful lot of time. And if we are going to gather proms and prems, and we have to do it through certain formulas, and we have to gather it all the time, people have to fill in forms all the time. And people do fill in forms. And within healthcare and with the new public management from the 90s onwards, when we should be more transparent and measure more, we get these questionnaires every day. And if you work out on the field, you don't get one questionnaire, you get 100 questionnaires. And then you perhaps consider looking at 10 of them, but you only answer one. And that is by coincidence and what you have time for and which one looks the best at this day. So it's very hard. We have to have automated data collection systems. And we have to be able to reuse the data we gather, not collect it once more. And that's all about interoperability and co-working. So the things we can do with modern technology is, this picture is soon 20 years old. It comes from the first internet explosion, and it is a bit awkward with wireless technology. If all you have done was to stop when you are moving to Africa and you stop on the telephone lines. And within e-health and telemedicine, we have a bit of this problem. We haven't really followed when it turned wireless, when you turned into the phone, like your 5G system here in Slovenia. It's powered by Ericsson. One of the first full-scale examples in the world, which shows that you really want to go along, and that there is something in Slovenia that makes Ericsson, we try there, because they want to do it. And that you should be proud of. Well, it could have been any other company. It just happens to be Ericsson. It happens to be a Swedish company. So, but there's no credit on me for that because I don't run Ericsson. But what are we doing and how do we use it? And there we have, when you have this strong sense of not invented here, and there is a strong sense with the digital development that actually lies outside medicine, God forbid. So this means that you can't only work with medical skills, you need to have digital skills as well. And you have to recognize that and share as same and equal partners at the table, otherwise you can't use it. So data and how we use that and how we use digitalization in healthcare is going to be one of the main issues. Can we do the paradigm shift we need to in order to know that we can work on different ways. And there's an enormous amount of resistance every time we take a tiny step. So over we got assigned by the Swedish government in 2018 when there were discussions about Paris and everything, and we had a scandal that had reached the press about value-based healthcare in Karolinska University Hospital. And there was really much noise and lots of aggressions and really not a very sound debate. So they assigned us to do an organizational overview of what is value-based healthcare. And value-based healthcare in its purest form is Porter and Theisberg from 2006. And that was also what was promoted heavily in Sweden. And we were the starting point for this. So there's a lesson to learn. This is not about being critical, but it's about thinking of how you're doing when you're doing this. Because you don't want this kind of fierce resistance that actually hinders you from talking about patients' outcomes. So when it comes to value or patient-defined value, that should be outcomes through cost. That's a very narrow definition of value. And that was the EU in its expert group and also the European Observatory, which this actually was a part of our work, took that we have to broaden the value concepts. And I'll come back to that. And when you have a narrow perspective on value, you exclude other values, like equity, like customer satisfaction, patients, and well, that comes into this. But I mean, there's lots of different values that you have to take into account. And also, its original form and where it comes from, I will show when we compare different methods. This is a market model. It's about which care provider should stay on the market and which one should not. So it's about comparing on the health economics at the micro level of the system. And this is, Nicola, you talked about macro, meso, and micro. Micro within economics is actually macro for the rest of the world. So it's important to think that microeconomics is not about the little tiny details. The organization, i.e. the hospital or the healthcare system of Slovenia or the insurance system, those are black boxes. Nothing of importance happens there because we can monitor it from above. So this is actually that's a very important point to keep. So, but if we switch then to, for whom are we doing this? For the patients. Well, we did, when we worked with the multi-sick elderly in Sweden, we did this framework because we wanted to understand, okay, lean, well, that's good. That's been very good for lots of industries. And it improves quality and efficiency enormously. But not if you try to do lean in healthcare. You have to do lean for certain groups. And if you look at this, if we have a care process, a defined process with an end, and then if it's within one silo or across silos equals clinics or primary health centers. So what we are used to and how our systems are built by tradition from the 18th century and onward, we have built within a silo the doctor and his team and what they are able to do. And they were not able to do very much in the beginning. But then it's evolved, then you have a simple process. And it's very important here to sometimes be able to think in systems theory. So a simple process is easily defined, you know what it is, and you know what the tools are, and you know if you do it, you get the results. And they are quite stable. But then you have in the complicated area, when it's across silos, then you have different clinics that do different things, i.e. a modern hospital. You have radiology, you have lab, you have care departments, you have different kind of surgeons, You have 50, 70, 80 different specialties where people know the lower abdomen and some knows the upper abdomen, and they wouldn't interfere or mess with each other, which is good. I mean, it's good if I'm a patient that they really know what they're doing and they're right. But if they have to work together, we have to have process management. So, and this is also at the core of value-based healthcare. You should broaden your horizontal scope and see what does it take in different steps in order to get a full care cycle. And we've been working with this for at least 30 years in Sweden, since the quality movement came around in the 80s. Then industry moved on in the 90s, but then in the 90s, healthcare started with quality improvement. And so we're working with processes. But then we have something that the innovations in medicine and medical technologies. We have the chronic diseases. They will never go away, but you can manage them. And then you have the result of this, that people live longer with different conditions. They don't die from diabetes. They don't die from rheumatism. They live until they're 70. Well, they need elderly care. We didn't have that. Elderly care for persons with RA in the 70s when I started work in healthcare. You didn't need that because they died before 70. So we have that today, and then you get this complex. So you have a simple process, you have a complicated process, and a complicated process is trickier, but it's possible because you can define the elements and you can get it right. A chronic, that's something that never goes away. They need to be monitored, preferably at home. And then you have the complex. And complex is where the system isn't stable because the different factors affect each other and it evolves. So if we then go to see what value-based healthcare, when we studied, and this comes from, we read everything up until 2018, or something, everything that was published. We read all the debate articles in Sweden, which were a lot because there was a fierce debate over this. And that's what you do when you're an academic. You try to go to all the sources, then do interviews, then see what they have done, and then try to make sense of it. And if you look at this, you can see that value-based healthcare starts from the top of the triangle. It's a societal model from the beginning. And then the techniques and tools are diminishing the more you reach the lowest floor. And to contrast that with person-centered care, which is one of the major developments, was actually invented in the 60s, but it takes time. You know, this is a conservative sector. But the basic ideas were around 65, 66, something like that. That's when the first literature is from. But person-centered care starts from the bottom. It actually starts from the individual patient, from the person. So these are two different. So and in order to get them to meet, it's not just to merge them and you get everything. You have to understand the different perspectives and the differences. And then you have lean and you have total quality management and those different. And lean is more of a managerial tool. It's about how aligning your different departments and then measure how they work together. So it's also a bit further up. It's at the meso level, not the macro level, but the meso level. And then person-centered care, it comes from the micro level. So, and these, when you cross from micro to meso, from meso to macro, something always happens because you need different forms of data or data in different forms. You need individual data at the bottom, and you need more aggregated data at the top. And then what we did, just to take it through, there's an article on our homepage when it comes to this that you can look up and read. So we had 3 university hospitals in Stockholm, Gothenburg, and Uppsala. At Karolinska, they went the full way. I actually was at the board of Karolinska for the beginning of that period, and then I was sacked because I was critic. But for 4 years, it was a consultancy-driven, consultancy-led project. The project leader was hired from the consultancy, and they should do everything from the beginning with value-based healthcare and throw everything else out. And that's where the big disaster came. So it came to a full stop, and you can't talk about value-based healthcare in Sweden, unfortunately, because you sort of try to bulldoze it over everyone, and then the resistance is there. And the resistance might go very far back in time when they resist, because they dismiss the new. In Sahlgrenska, they used it used consultants and worked for the value-based model for 1.5 years, and then they changed the managing director, and then they sort of opted out and went about to do their own thing. In Uppsala, the only hospital that still talks about value-based healthcare, they did it from the beginning by themselves, engaged in outcomes measurement, and used the old lean process thinking that they have been using and built on that. So that they built on the sediments they had, which made it more effective. So just to summarize this, it's originally a fundamentally governance model on a national health system level. On an operations level, it resembles, but it's not the same as multiple other techniques. And it sprung off from the market logic, which is not really the case in Europe, because we have different value drivers, the fundamental value drivers in our system, with equity and equal access and stuff like that. And even though it's emphasis importance for the patient, it's the aggregated patient. And I'm very pleased to see when Peter is talking that you have to go beyond that, and you also have to be at the micro level to gather. And that wasn't in the model then, but it's now, and I'm very happy because that's a good development. So just to conclude, I just want to say that economy is more than money. When we talk about economy, we have talk about financial things. And financial for a state is different from a budget within a hospital. So we're not even talking about the same money. But if you think of, if you're at a restaurant and you want to split the bill, I think you have been to a restaurant, yes or no? And then sometimes you split the bill, and that's a very easy task. It's just pull your computer out of your pocket, and then you divide it by the number of persons. But it turns out that, no, I didn't have that. And if you're a student, I'm poor, I only had water and a salad. You had a bottle of good wine. I couldn't afford that. And you start to get all these discussions. Being in research is, of course, a friend that has done studies on this just to see what's the value implication of splitting a bill. And you can see that you have a multitude of values that comes into place. Is it the first date? Should the man buy, or should it be modern and the woman pays for the food? Or how should you do it? And there are a lot of economic distribution values that you have to take into account. And the thing is here, a simple problem of splitting a bill is not the standard situation, because the situation varies and the paying capacity varies. The coordination between different actors is required. You have to do that because you have to negotiate. And there are multiple values and different values for the different stakeholders. And the take home from this is that you should start right with what you do, know the different values in the room, and don't skip important steps of getting a clear vision of that. Create solid arenas for cooperation. I think now you've heard it from Nicola, you heard it from Peter, and now you hear it from me. That's a fundamental issue to do. Because no model is perfect in the beginning, so you have to be able to adjust, and then you have to have all the stakeholders at the table. So that I'm stressing this just to say that you should move forward, but you should move forward in cooperation. And use the improvement cycle, like Peter showed from the Netherlands, and show real results with the real figures. Try to have as raw data as possible. Try to have as good a financial perspective as possible. And don't put the financial perspectives on the floor. Let them just do the healthcare and have experts aside that actually can do that. So you need to have administration, you need to have economists, you need to have HR people, you need to have tech skills, you need to have a much more varied competence base in order to manage modern healthcare. Because we can't solve the problems with the old solutions. So you have to be adaptive. This is an actual bridge, but the flood turned, and the bridge is not used that much anymore. And also remember that governing on a distance is like learning a children's party by text messages. It's okay to send text messages to 3-year-olds, but they can't read. And they won't eat in the right order or do anything, because they will do. And you can send hundreds of text messages, they won't read them anyway. It's like you can send 100 questionnaires. If they don't even get the results, it's not going to affect any behavior in healthcare. So I think you can read this when you get. Focus on, now I'm finally on the end, so you're going to be happy in the back. I want to leave you with some good advice. The first one is be skeptical to all universal models. It's very hard to build a high-rise with a Swiss Army knife. So when it comes something that solves everything, be skeptical and look about. And I'm also happy to read in your that you are aware of this from the beginning, and that's a much better vantage point. And grand models of grandeur, sort of, this is the best model the world has ever seen, and I made it. Well, that's more a Trumpism than a statement of fact. And trust your own experience. Move on and revise. Do it in small circles, small learning loops all the time. But the most important one is be skeptical to all good advice. Thank you very much.
Thank you very much, Hans, for the sincere words. We don't have problems with skepticism in Slovenia, we have more problems with trust. Spoštovane in spoštovani, zdaj je pa čas za...
Now it is time for questions from the audience. Normally in Slovenia, if I moderate in Slovenia, don't go all at once, because we always have problems. So many hands are raised. So one by one, please. But this was, of course, an irony. We also have our guest from the Netherlands still online with us, so you can use his expertise. He won't even see you, and therefore you can safely put the first question to him, perhaps. We have the first question, the mic.
Thank you very much, Hans.
Gregor Cuzak. V angliščini ali v...
Odvisno za koga.
So it will be in English. Perhaps to Mr. Debay, but also to the other two speakers. First of all, thanks to Pharmaforum for actually promoting this quite important topic. I'm really happy to see co-authors of the Blue Book here. More than half of us are here. So, value-based healthcare, together with the skepticism that Hans brought forward, should not be a zero-sum game. It means some gain, some lose, but it should be more. And if you want to introduce a new concept, everybody should gain more. How is this possible, Mr. Debay?
That's a good question. You mean, how is it possible for everybody to gain from this methodology? So I believe that this approach is fully focused on improving value from a patient perspective. And what I see in our hospitals is that this really motivates our care professionals. So they are very much intrinsically motivated by working this way. And as a society, we have huge problems, at least in the Netherlands, with a lack of capacity, with continuously increasing costs. And we believe that this approach really contributes to a more sustainable model that will be more long-lasting. And in this sense, we actually do all gain from this perspective. But maybe I've misunderstood your question.
No, fine. What about Nicola and Hans? What do you think?
do you want to start?
Perhaps I should.
Well, I come to think about when we started measuring in Sweden, and we launched an open comparisons based on our quality registers in 2006. The resistance was fierce. No one wanted to be compared to any other. Every measurement was. Do you think I should stand up? Yes, I should stand up. Every measurement was bad and wrong. According to this, we have lots of skeptics in Sweden as well, even though we're a cooperative country. But I think that's when you turn that point, when even the professionals, the medical professions, realize that they can achieve better results, then it's not very hard to get them to go all in for this. So, but it's you have to reach a tipping point, because and that's where you need to unite and gather different actors. But if you reach that tipping point, which I think that Peter has done in his hospital group, then you can't stop it. And we see this over and over and over again. I mean, we thought Japanese was very strange, funny, Asian, built cars in an Asian way. No, they built cars in the same way in Europe. They started the first factory in Turkey, and they whipped the shit out of BMW and Volvo and everyone else, because they had something. And the intrinsic value is that you have to see the value of doing this. If you do that and you get the results, then I think you're home. And then you can see also that it benefits all.
Thank you very much. Nicola?
Thank you. Just adding to what colleagues have said, I think what's also very important is to really extract value from the debates that are happening in a European and in an international context. These are not so remote and not so far away. Everybody's going through similar sort of experiences, and that kind of dialogue, honest, open, very transparent dialogue about what is working, where the real roadblocks are really important. And I'll come back to a point that I made earlier, linked, I think, to your Esprit. I think it's very, very important. Of course, the patient in an individual setting with his or her doctor and shared decision-making, but patients are operating also at many different levels. They are an absolutely important force for good, because they can bring perspective, they can bring knowledge, they can bring experience, and they must have a seat at the table. And that's why it's so vital that organisations like yours in Slovenia and the European Patients Forum have that powerful and united patients' voice, also to engage in some of the societal debate that will help to demonstrate the added value for all players across the healthcare cycle. Thank you.
Small steps and transparency for the start. Zaenkrat nismo videli vprašanj.
I don't think there are any more hands raised. I think that we should all do good with some coffee. See you after the break in 15 minutes. Oh, it seems that we have another question. And then in 15 minutes, we will go back to our hall. We will return.
Hi, thank you so much. Really insightful presentation. Maybe this is for Peter. You've been working on this for 10 years. And you said in your last slide, important to align on value. And I believe value is defined obviously by the patient and the customer, and it changes over time. So how have you seen what is value, and how has it changed over time? Meaning, what are the most important outcomes in today's context? Out of all the outcomes we're measuring, what are your most important ones now in today's healthcare context?
The way that we define outcomes, it's at the micro level. I'm going to also refer to the speech from the last speaker. So it doesn't really change over time. I mean, when I talk about outcomes, it means outcomes from a patient perspective for a particular patient group. What I do see evolve over time is our ability to actually measure those outcomes, including PROMs, the patient-reported outcomes, and become much better at understanding what these outcomes mean and how we can implement them as care professionals, and indeed use them as well for better decision-making. But the outcomes itself are actually quite universal. I mean, these are things like quality of life or the ability to go back to work or the number of complications after surgery. It can be many different things. It depends on the patient group, but it is quite a universal concept, I would say, but it's really measured. I mean, my definition of outcomes is the results that matter most to patients. And when I worked at the International Consortium for Health Outcomes Measurement back in 2012, when it started, that was the definition that we used, and it is the definition that I still use today.
Thank you very much. We have another question maybe before the coffee break.
I already started speaking English. It was planned that I speak Slovenian anyhow. I don't see any more hands raised. You are invited to have coffee. We will see you again in 15 minutes. Have a nice break.
razmišljanje o smelih idejah, ki jih nekje že uresničujejo. Pri nas pa jih bomo začeli, kot smo danes slišali, preudarno, ukolikor bomo poslušali govorce, ki so danes predstavili svoje iskrene misli
They
in
presented their
izkušnje
sincere
z
thoughts and
majhnimi
experience
koraki,
by first taking
transparentno,
small steps, by doing it in a
vzgojno bi
transparent
skorajda
way.
lahko
Let
rekli
me
za vse
say
deležnike.
that it will
Torej,
be a very
predpogoj
good
uvedbe na
experience for
vrednosti
all.
temelječe
The
zdravstvene obravnave v
precondition
zdravstveni
for
sistem
introducing
je prav
value-based healthcare
pripravljenost vseh
is in
deležnikov
fact the
za
willingness of all
sodelovanje in
stakeholders to
za
cooperate
spremembe.
and to make
Mogoče bi
changes.
veljalo v Sloveniji besedo
Perhaps in
spremembe
Slovenia the word
spremeniti v
change
kaj
should
drugega,
be
kot smo
changed
spremenili
into
probleme v
something
izzive,
else,
pa se
as
mnogo
we
lepše
changed
sliši.
problems into challenges,
Zdravstveno
and this is
osebje,
a nice
ki je v tem
sounding word.
procesu ključno,
As for medical
mora biti
staff who are key
pripravljeno
in
v
this
proces
process
obravnave
must be ready
vključiti
to
bolnika,
include patients
upoštevati
in the
njegove
treatment
preference
process,
v
take into
procesu
account their
zdravljenja.
preferences.
In z okroglo mizo v
The round
nadaljevanju
table
postavljamo
will
v
now
osrčje
put
prav
at the
izide
heart
zdravljenja.
the health outcomes.
Bliže zato vabim
I would like
moderatorje
to
okrogle mize, na kateri
invite
bodo
our
te izide
moderator of the round
postavili
table to
na
come
domača tla.
closer, and they will present the Slovenian side of the story. Dorian Marušič has different career experience. He wore several hats. He was the medical director of the Izola General Hospital, state secretary at the Ministry of Health, advisor of the general director of the Slovenian Health Insurance Institute, but also the Minister of Health. He is currently teaching at the Faculty of Health Sciences at the University of Primorska. I believe that he also brought some rays of sun to Ljubljana. Please, Dorian, the floor is yours. Thank you very much. I really recommend this booklet for reading, but not in the evening, mind you, in the afternoon, where you have a clear head, where you have focus, so that we will be able to embark on the challenges that undoubtedly exist in our healthcare system. Our setup is slightly different, which is why I will have to change my seat because I don't like this. I'm an active person from the area of Primorsko. We are very active. We like to move around. As for the round table, today we will make an attempt to deal with what should be the first steps when introducing value-based healthcare. I would first like to thank our organizers for putting this item on the agenda of today's conference. I would like to thank both of my neighbors for presenting starting points. More than 10 years ago, even 2 decades ago, late Professor Hilder told me on one occasion something along these lines. I traveled the entire world, I saw many countries, ultimately I found a solution at home. First, I would like to thank all our 3 excellent speakers who presented their experience, highlighted a very important challenge ahead of us, that this is something that the European area already has, but it is possible to compete. Slovenia can be involved among those countries who also introduce value-based healthcare models. Of course, when speaking about values, we need to first define them. But today we have 4 guests at our round table. When preparing, some were eliminated. Initially we had 6 or 7, now we have only 4. But they are probably strong advocates and believers in the concept. We will try to speak about them, about whether this value-based healthcare concept is well known or is it recognized in Slovenia, what are the key steps that we should undertake today, in addition to our conference, what should be done tomorrow, how we should start along this path. Our speakers presented this path saying that value-based healthcare is not a solution for all the problems we encounter in healthcare, but it is an important tool in order to promote quality and safety in healthcare. It puts our patient closer to the center, it directs patients towards the center, where patients in fact should be placed and positioned. We also heard that we promote integral care, promoting preventive activities, early diagnosis, treatment, and also based on the local community principle. We have done a lot. Probably all 4 speakers in the round table will say what has already been done in this area. But as I have said, this is not the key panacea for everything when it comes to the reform of our healthcare system. But it is a very important tool along this path. And of course, we will have to include digitization as well. Data collection, analyzing them matters, then preparing information, helping patients to take the right decisions. We don't only need the patient's opinion, we also need to hear the views of all stakeholders in the healthcare. We need some sort of umbrella action plan, which is why I think it is a good idea to invite all my 4 interlocutors at my round table. I will start with the order that has been prepared to me. Anka Bolka, Head and Director of Field of Development and Analysis within the Slovenian Health Insurance Institute. I will first invite ladies. Full Professor Valentina Prevolnik-Rupel, Scientific Counselor, Institute for Economic Research in Ljubljana. Associate Professor Dr. Petra Dušenović-Bonša, Head of the Chair of the Economics in the Faculty of Economics in Ljubljana. And of course, last but not least, to maybe equate this sexual imbalance, to strike the balance. We were doing quite well because we have been promoting females. Our Aleš Rozman, a doctor, MD, University Clinic at Golnik. I have put several questions. It would be very difficult to answer by simply saying yes or no. I believe that you are concise, because I know you quite well, I should say. Hence, we will also leave some room for questions from our audience. I will use an informal address to address them, because I've known them for ages. Well, really ages. Katka, in your opinion, how well known is value-based healthcare in Slovenia? Is the concept known or not? Thank you. A warm welcome to all, and I would like to thank the organizers for choosing this topic and for inviting me. Thank you for your question. And also vice versa, I will use an informal address. Yes, I do expect that you use this. How well known and recognizable is the concept of value-based healthcare in Slovenia? When preparing the guidelines that are at the back of the table, among other things, we also conducted a survey. We included all the stakeholders in the Slovenian healthcare system. What we learned, about 14% of those questioned are familiar with the value-based healthcare concept. We also learned that about 47% among all those who were surveyed, we had 306 in the sample who provided answers. They said they have never heard about this concept, which was quite a paradox, and I can quickly mention this because you said that I am precise. Out of all those who were questioned, I believe that 81% answered that they believe that the concept would bring benefits in the system. But many said that they are not familiar with the concept and they still believe that it would bring added value or benefits. Of course, we can debate when we interpret these results. However, this is the foundation. Aleš, let me turn my question to you. How well known is this system among providers of healthcare services? Do you see that there is a potential to introduce the concept not just at the level of your clinic, Golnik? Some PR. More than 10 years ago, we introduced the system of accreditation, and this hospital was included as well. Assessors in the US wondered because they said there is no such hospital in the US. Thank you, and a bit of warm welcome to all. Yes, about 4 years ago, I was appointed director. Porter was the book that was handed over to the colleague from abroad. I went through it months after months of value-based healthcare, and I thought this concept to be very attractive, and I still think this is the case. Yet, it stems from the US, this should not be forgotten, where medicine is slightly different in terms of economic categories. The main idea is, where do I get the most for my money? Hospitals, providers, in fact, record their health outcomes, where patients were treated with fewer level of pain, where this was done the fastest, with fewer side effects, and this should be done at a moderate price. And they compete in the US, where it is the best valuable system, where the costs are the lowest and the quality the higher, then the provider is the best. Slovenia has a slightly different model. When it comes to whether this system is recognized in Slovenia or not, it's quite deficient. We are in the initial stage. And I think that we should work more on this, that direct providers recognize this as a valuable method, but we need to also be aware that banana has great fruits in US, however, you cannot grow bananas in Slovenia, unfortunately. You have been working and analyzing the healthcare system for years. You are also teaching at the Faculty of Economics. Those who want to pursue healthcare management are your students. Petra, do you think that this system should be relevant for the Slovenian system? Aleš mentioned, where do we come from? What are our reservations when it comes to transatlantic experience? But also we brought some good things across the Atlantic, right? Well, whenever we speak about this concept, I'm a bit bothered because we say this is a novel concept. In fact, this is not the case. It's about the fact that we are intuitively doing it in this way. We are continuously trying to improve our methods, health outcomes, but now finally data and technology enable us not to do it within only a quality management system, but we should move up a notch. And sometimes if you have too narrow of approach, the result is not good. I believe this is a good approach. However, we should be careful when it comes to implementation. We have just been saying that the familiarity with the concept when it comes to healthcare providers is poor. What I'm concerned about, and maybe this is an appeal, what we should be careful about when introducing the concept in Slovenia, we are not so much discussing data collection. We have plenty of years of experience abroad and we can translate their experience, but we should focus more on how to use the data. This is the problem. The problem that we all have, that we are dealing with this area, is that we collect enormous quantity of data, and this is the frustration of medical personnel. There is no feedback. For providers, we need to provide them with feedback. Only in this way they will recognize this concept and its value. But both providers, researchers and payers need this. In my opinion, this is of key importance. We collect data, but for every stakeholder we should give him or her the right data information that is useful for him when cooperating within the healthcare sector. Yes, also when it comes to healthcare, one of the most important problems or points for debate is money or resources. We also have to negotiate with the payers sooner or later. In Slovenia, we have the privilege of having only one payer of mandatory health insurance. Before putting a question to Anka, let me just say that when presenting the guidelines, the Slovenian National Insurance Institute also presented all the data they are collecting. Of course, they are limited by data they obtain from providers, but it was presented on 2 occasions in conferences in Slovenia, how they collect data. For example, hip surgery, where certain parameters are measured. Not only within the closed circle this is presented, also to the general public, also for users. In a nutshell, Well, I maybe put words into your mouth already, but anyhow, what is the view of your institution when it comes to value-based healthcare? How far are we? Could your institution promote the use of this model? Well, we are the payer and we come last when we need to pay for these services. I strongly agree with Petra, who said that we really have a large quantity of data. Since 2013, our institute about paid services per individuals in electronically format transmitted to all. And this data has been used for secondary use purposes. I believe that they should be used even more. Also, when it comes to indicators, we also use the data, but these are merely indicators that could be obtained from administrative data. They develop gradually by different specialties. In institutions, we included those activities where expenditure is the highest. We follow that order, not everywhere, but where this could be done, and this data is publicly available. As for the Institute, this is not anything new. As we have established, we have been doing it for a long period of time, not only indicators, but to pay and purchase in the most rational way services that enable best health outcomes for our patients, and that we can use the money most efficiently, as of course our funds are limited. In the future, this gap will be bigger when it comes to the needs on the other hand, on the one hand, and resources on the other. And therefore, it is in our interest to promote this concept even further. Yet the question is, what is our competence within the system of regulations? Because regulations are really outdated. We have a very rigid system of general agreement, and whether we can really support such innovative approaches. As we saw with our speakers from abroad, every project calls for a pilot phase, and it is quite long. And to insist on that, to fund this, well, certainly it is a complex task indeed. Thank you, Katka. Our speakers at the beginning presented experience from abroad, not only some barriers standing in the way, but also second thoughts. But they also spoke about this gradual approach, this pilot phase, a long-term framework for the introduction, but this starts with step one. We will have to begin. And if I give you something that you need in order to introduce this model, where should we start, is my question to you, and what do we need in order to start in the first place? Yes, indeed, all the speakers told us that we need this gradual approach, not everything should be done at once. We need a pilot phase of testing the system in practice. If I want to convey one clear message from today's conference that it sticks in our head, yes, value-based healthcare is not the approach across the board for all medical conditions and sectors. It cannot be universal. It is very important which areas we will select and where we will start. When writing our guidelines, I believe that we as authors really learned quite a lot in the process. And many countries abroad, because they chose the wrong area, the wrong sector or specialty when introducing the concept, they failed. For that reason, it is very important where should our focus be. Therefore, the authors looked in detail about what criteria should be used to select specialties or areas where we could introduce the model with the greatest success. One of the criteria being that indicators for health outcomes are already out there. We do not start from scratch, and we just upgrade them in Slovenia, which sometimes, of course, are not comparable between different countries or providers. There was one criteria, the size of the population, the number of patients, because if it is a small sample, then the concept is not successful, it doesn't add any value. Then homogeneity of patient groups is also very important. There are certain criteria in place based on the experience from other countries, and they have already dealt with the introduction of this concept. And Slovenia, in our guidelines, also set and defined some areas, specialties, which in our opinion are most suitable to introduce this concept to take hold. Our expert group of authors identified cardiology, for example, arterial fibrillation and orthopedics. We mentioned lower back pain, hip and knee pain. So these are, for example, the areas where we think we should have a gradual pilot introduction of the concept. I was happy to hear from our State Secretary, who spoke about great breakthrough in the area of digital IT system, digital breakthrough in this field. I do hope that healthcare system will open its door, that we will join at a fast pace to all who break new ground or are far ahead of us in the European context. In our guidelines, we also presented the chapter on IT system digitization. I believe that initial investment is about 3 million, if I'm not mistaken, in order to join and connect to the existing infrastructure and network called e-health. Let me go back to the payer. What do you think? As an expert in IT systems, should we achieve a faster breakthrough when cooperating with all stakeholders, including your Institute of Insurance? Do we have support infrastructure to introduce the model to Slovenia? Well, as I have indicated already in my previous answer, most certainly. We have done quite a lot. Many things are already in place, but what is the key deficiency? We lack one stable conductor. We have the system called e-health, but maintenance is too slow, we do not upgrade it, we don't address the issue of deficiencies. This is not done and eliminated at a fast pace, and this is a problem. I do hope that with this strategy called e-health, I believe that it will be completed this year, that we will make this program, that we will take a giant leap in the right direction, and that it will be clear who will fund this. What is the problem? If we get some European funding or any funding for developing solution, setting up certain systems, then we forget about maintenance. It is very complex to maintain solutions. It is in the long run. It takes forever. And we speak about huge amounts, and you need to provide them continuously. You need to upgrade these solutions. And here I believe that we need to agree at a state level who should be the coordinator. I believe that the Ministry of Health is the answer. They are the right stakeholder to look beyond, to see and to steer the process, to have the control of the system. And we should raise the level of quality in this respect. Aleš, I will put a question to you, because our respondents pointed out to this. They spoke about there is a lot of potential when it comes to this model of value-based healthcare, but they point their finger at the Ministry of Health and the National Health Insurance Institute of Slovenia. But you are a doctor. What do you think? What is our key problem? IT system, digitization, motivation, knowledge, expertise? You are a doctor. A managerial question comes later. But first, as a doctor, I think a problem has several layers. When we have similar conferences, providers and doctors do not sit. They are not invited. When we speak about IT system, they are not invited. When we speak about better efficiency, nobody wants to speak to them. IT system, software, guidelines, what should be done, there is some sort of resistance. because this is not considered in the right way, how they should make our life easier, but they complicate our work. Years ago, we spoke about computers should make our life easier, but then you have upgrade one after another, which is a problem. And this is our pain of us as direct providers, nurses and doctors. We say that why they are leaving the system, because they have to sit in front of the computer, clicking a mouse, complete all the forms and data, and you can do it faster manually, and this should be said as well. This is one thing. Then secondly, I really don't know about the concept. Of course, it calls for some strategy, as Katka has mentioned, not across the board, but pilot models, selecting certain specialties. Selective hip replacement surgery is quite nice in this respect, because we have been practicing this when we were younger residents, anyhow. But we need to take into account a broader view. All the pores or everybody should think about this, even when we have elderly patients who are not mobile, who have several chronic conditions. We also have to introduce this concept there. Petra, I will put a question to you, because you also teach future managers. How should they translate this into practice, what Aleš has pointed out to, this shift? A similar question was posed to me by journalists. How about digitization? Will it solve everything? Also the issue of a lack of healthcare personnel? I said never. Indeed, when we were listening to the presentation, one thing was highlighted, and this was support. When we look at the healthcare team, we speak about nurses, doctors, and other medical staff. But the team today and the team in the future, this will be a huge difference. We spoke about the progress, advancement in the hospital sector to share and exchange good practice examples. And they should have support from data analysts, and we don't have that now. If we expect that the burden will be placed on doctors or the head of the team, this will not happen. We see this everywhere. We don't have enough medical staff, but we expect that they cooperate in the research, conduct research, introduce novelties. They have to be involved, but they need to be supported as well. If you ask me what is the greatest challenge for us, indeed knowledge, because in order to analyze this data so that we get templates for change, this would be the most difficult thing to achieve. And we also need to look into what in the Slovenian healthcare system we should be invest into. 4.5 billion a year, the whole expenditure, collective and private. And we speak about the share, what is funded by whom, and the payer. Well, they speak about low operational costs of the system. When we compare different healthcare systems, we should also see how much money is invested in the coordination of the healthcare system. And we will have to invest more in this coordination. Otherwise, we won't have this positive impact. I think it is worth it, because we heard at one of the slides, OECD study presented that 25% of health expenditure is wasteful, meaning that we offer services that they don't contribute to health outcomes. They can even harm patient status, which is quite a lot, 25%, mind you. And of course, we will have to redirect money to serve other purposes and to provide support in order for the system to function. Just internal motivation, well, the system doesn't work based only on that. However, internal intrinsic motivation should not be overlooked. You saw an example from hospitals on the slide previously. Only if we give information to providers about differences in health outcomes without giving them a single euro, this leads to change. The study results shows that this intrinsic motivation is 4 to 5 times more powerful than money, and we should exploit this, which is why I think it is important what I have said initially. The data should be converted into information that we can change delivery, healthcare models, to enable researchers to work in the field, and the payer can also provide resources for payment. We don't have a representative from the Ministry of Health here today, but our network is very rigid. It hasn't changed for many years, but it is of key importance to discuss what provider will be doing what. Our network today is too fragmented. We will have to exploit the economy of scale to agree who will provide what services where. Well, this will, of course, depend on health outcomes. Aleš, do you want to reply, respond? Less about internal motivation. This is really the real thing. I completely agree. Healthcare providers enjoy modifying their work so that it is patient-friendly, it is labor-intense. I had several attempts. We also introduced this model from our outpatient to inpatient clinic, but the problem is that a manager should not allow this. And then we have treatment that in terms of time is friendly, more quality, but from one payment model to the next, the result it generates a loss for the hospital. And therefore you have a problem, you have a headache. I apologize, I have to intervene. Undoubtedly this is the case, but what is worthwhile? We are limited in our public healthcare system about the payer cost. But what about this social value model? Unless we take this into account, we won't successfully introduce telemedicine solutions. There are many positive impacts. The changes stay outside the scope of the healthcare system. It is undoubtedly the case, which is why I say information should serve providers, the payer, but also the regulator. Katka, if I can respond, because we just started, let me remind you that value-based healthcare introduces exactly this. It is a patient-centered approach. It brings together different types of treatment, hospital, prevention, primary, secondary care. We have the so-called bundle payment system. And if we move and make a transition to this system from the perspective of payers and providers, then we no longer have this problem. This is the first round. Maybe you sense that in the first part I wanted to highlight inputs, investments, the role of the payer. Unfortunately, we don't have the minister here. Lack of providers, not enough medical staff. Maybe we skipped some red tape stuff, but we will turn off the light, we will turn on the light again, and now we have the model, we have the concept. Value-based healthcare system. Well, not immediately, because we can vanish, but the system works. Let's say it works in Slovenia, but what happens then? Who hopes to say, who will announce what might happen once we have the system in Slovenia? Because in Europe they already have it in some countries. I have the mic in my hand, I will start if I can. I expect to have more satisfied providers. It will contribute to this, that we won't be losing them, they will not be leaving the profession, as is the case now, especially in the public healthcare, because they are not satisfied, they are not in line with their mission. I believe that healthcare providers, doctors, nurses will be more satisfied, the same goes for patients, then more rational and flexible healthcare network, basket of benefits will be different. We have a very rigid system, the so-called general agreement with pluses and minuses, but the needs are changing. What we provide, what we offer to patients for this money, well, it has to be amended continuously, more often. This is the impact that I expect, and above all, I believe that the coordination of the healthcare system, I believe that all in Slovenia have the greatest problem with this, will be better because it calls for greater transparency, information, and taking decision on the basis of objective criteria. This was the question for all. You can wear the hat of a provider, payer, even a patient, because maybe we wake up and become patients when it comes to this new concept. Well, not enough to add, because she summarized very precisely what should happen if, by miracle, the system was introduced to Slovenia. What are my expectations? Certainly that providers of healthcare services at primary and secondary and tertiary level are relieved from this planned economy concept. There should be some competition between different institutions, because this is what spearheads development. You have better service at a lower cost. And this is the area where you introduce innovations, you want to come ahead, you want to be in the pole position. This, in fact, now poses problems for our system. We don't follow the patient. They select the provider where the best services are offered, and they can get more, not for their money, but also they benefit their health and the society as a whole. I think this should be overhauled, that it is possible that one institution also prospers and some institutions go bankrupt, and then we have new kids on the block who are more successful. I think this would in fact speed up the wheel of development. If I may, what I expect, better transparency and cooperation of providers, because the system as a whole cannot integrate this system if we don't have transparency. The system rests on this, that health outcomes are publicly available. First, they are published within the institution. As we saw with one of our speakers, there are some steps, but in the end, our objective should be that results are compared. And only when we compare them can we move ahead, we can research processes and transpose good practice examples. First, I expect transparency, cooperation, but I would like to highlight that to have the full-blown effect, this is only possible when we involve all. If we act, well, if the introduction of the value-based healthcare means that we will have the same model as we have now, some enthusiasts in hospitals, which is really positive and commendable, not to be mistaken, but it doesn't allow for complete full-blown impact of the concept. Only if we have more providers, we can compare, we can benchmark and transpose good practice models. The model is not intended to penalize or sanction anyone. We don't point the finger at anyone, but to find a good practice example and transfer it to other institutions. Again, cooperation and transparency. Yes, on behalf of the payer, somebody who is collecting contributions of insured individuals, and then based on this we pay for services. I expect health outcomes that we will provide for everyone so that his or her health outcomes will be really good. I'm a bit skeptical here. My father used to say, I would enjoy to have 1 meter for pain. But will we be able to find the right metrics? This is of key importance. Somebody wants this, another person wants that. I would like to have better haircut or hairstyle. Does this fit into this basket of benefits? Here I have problems. I don't really know whether we can do it today or maybe just to go into the future, to leap into the future, whether we really have the conditions to get all the data and to have these standards. But I agree with all the speakers, indeed. But will we be able to do it? Well, probably I won't be here when we discuss this. If I may respond to this, the dilemma is often being raised about whether indicators are subjective. Can patients really report on themselves on outcome measures? I believe that 5 years ago I worked at ICHM, that is the organization preparing indicators, instruments to measure certain outcomes by patients. These indicators have to be subjective and they are intended as an add-on to other indicators. We can never decide solely on the basis of subjective indicators, but there is a combination of clinical process satisfaction indicators and together with case mix variables. This enables us to have a good comparison from different populations of patients in different hospitals. So these subjective indicators are just an add-on. And this skepticism that we are witnessing in Slovenia, maybe it also stems from this, that we have too many indicators developed. If everybody should have his or her own indicators, we cannot provide for transparency. And ICHAM was set up in order to collect this minimum set of indicators that provide for comparability. They are the most suitable to express a health outcome that is relevant for patients. Probably you persuaded the audience, which was also my purpose, but you are the authors and you should believe in it. Let me be the devil's advocate. Let's say that we will all be in the future when we have value-based healthcare. We have 3 or maybe 4 main actors. Patients in the healthcare sector at the center, we have payers, we have providers, and the regulator. The regulator will have great problems how to maintain this network, which hasn't been touched since the Second World War. How will this new model be put into place? How about the payer? How will they approach providers? They will have a negative gradient of quality in the last period, let's say. It will be below average given measurable indicators. How about providers? Because they won't be able to achieve a certain level and threshold of quality, and then of our poor patient, how this poor soul will be able to decide what product, so to speak, to choose, where to purchase it, whether he or she will have to finish the medical faculty in order to do it. More complex the model is, the more difficult it is to manage it. Of course, we get better results, better satisfaction. However, there is some path, and I will now play the role of the devil's advocate. The ministry, the payer, the provider, and then I will open the floor for our audience to put questions. Who will go first? Who wants to go first? Maybe initially. Some short reflections. Slovenia has a system of public healthcare institutions. We also have some private institutions which are gaining in strength. Those who work in both institutions at the same time see a great difference how these systems are managed. Public healthcare establishments should be converted and introduce a different model which would resemble more private management institutions. I'm not saying that we should undermine the public healthcare system, not at all. We can go to private providers and we are refunded, so it is not an issue about that. Ultimately, if there is an area where they cannot provide certain services, they are below the threshold, then in the market system, this goes bankrupt. But then there is the money where some hospital, which is doing well, would take the money and will take the franchise. We have the hospitals abroad with a franchise across different countries, and some things will disappear, but they will start from scratch and another player will come into play. At some moment, we have to make sure that the market mechanisms are established. Otherwise, we will have difficulties, I fear. Why is this network so rigid? Why it is not changed? I believe the main reason are local communities, people, which is patients. These are patients. Why? You started nicely about our poor soul, our poor patient. How will he find his way? Ignorance is bliss, in fact. Today, not many people know what might happen to them. The consequence of transparency, better informed patients, they will not oppose the reorganization of the network as they do now. They will better understand that if we maintain the rigid network and capabilities where quality is not provided, is not in their interest. Therefore, well-informed patients are of key importance. In history, I believe local communities were the main reason why the network hasn't changed. If I consider the regulator, I won't be happy with it, if they will complain and whine. We are a small country, we have a great benefit to have just one payer. Most of the network is still state-owned. Well, if we are not capable of overhauling this system in such a state where things are connected and to introduce change, then we should ask twice. Do we have the knowledge and will to really change these things? As for providers, I believe that we are underestimating them. Today, every provider has to think twice about formulating a strategy, what is their future focus. Providers know very well where, for what programs they are understaffed, where they generate loss or profit. Maybe it is not communicated transparently, but they know how things are done, what is the situation. And in my strategic management, I'm certain that they will come up with solutions. If possible, good practice examples will be translated and introduced. But first, they need to be identified. And this value-based healthcare model enables this in the first place. I believe that we have plenty of tools available. If we fail, then it is a sign that we don't want to do it because of private interests, or we lack enough knowledge and expertise for that. As for the payer, from the payer's perspective, if we speak about transparency, it is not a question, I think. The system should introduce minimum conditions where providers is allowed to provide services in the first place. If it is below the threshold of appropriate quality, then this provider should not be in part of the network and should not be paid. And then again, incentives for those who are better achievers. I don't see this to be a problem. Maybe the only thing that I would add, and I agree with all who have just spoken, data. If data is at the heart of the system, the data for which in advance we identified are a must and will help us take decision, then we satisfied all the sides. It is visible where we have good practice examples, patients know which provider is the best, the payer knows who to conclude a contract with. As for value-based healthcare, it is not necessarily a red tape system, but of course you need to collect data in advance to determine what purpose they should serve and how we would analyze them and who will have use for this data, who will have access to this data. If this is clear, if this is processed quite well, if we compare the data and we will take decision based on that, then the question who is in the network or not, which provider should be contacted, what will be the greatest level of satisfaction, these questions are then addressed and resolved. Thank you for lifting the fog in Ljubljana. The ministry will create the network, we will have incentives, the payer will be able to purchase strategic services, and all of us, patients, will make a better choice. Anyhow, we still have some barriers in our society. I'm happy that one of the experts in our healthcare system was kept returning. At the last meeting, you presented quite nicely all the barriers standing in a way, also in our head. When you spoke about hierarchical and network management, maybe just some word for you, then some questions from the audience. And the last question, I was given 1 hour and I will fully exploit this with my roundtable participants. Thank you for this opportunity for the intervention. Just briefly, if I summarize what I had said about a month ago, it was the story about how to take decisions in Slovenia, but also in general, the concept of governance. What was my assertion? Often we imagine that decisions are taken in a very hierarchical way. What the minister says, this will happen within the healthcare system. However, in practice, we have network decision-making and management where we need to reach an agreement. We have many stakeholders and they are needed in order to make changes. But there is one question I would like to raise this and put a question to all of you, if I may. If we say that it is not enough and the ministry should be the only one to take decision about value-based healthcare, but how about you as stakeholders? You are the force that would like to nudge the ministry and keeps on pushing, we want this, we need this. Who is this? The national the insurance companies, you as experts, patient associations, you scientists, without any secondary agenda or hidden agenda. Mircea, thank you for this and for your question. Do not respond as experts. Experts did a lot, they wrote a book, but our commitment was to implement this by the last second we live. Please, the answer. Mircea, I should choose only one? So you raised several actors. I believe that everyone should be involved, everyone, because it is in everybody's interest, or should have it, if we live in the ideal world. But I believe that patients first, probably. Here I think, and it was raised already, that the payer plays an important role here. All financial incentives are very important, or at least they shouldn't be a barrier. When we introduce changes, as we heard, it is possible to introduce cheaper ways, models, to transpose hospital treatment to daycare, outpatient treatment, but then the payer needs to endorse these payments, and providers also need to understand that this means that you don't preserve the same level of payment if it is done cheaper. The provider should also see what is the benefit for introducing a change, what is the price, and ultimately you cannot be worse off. But we are always better off as a society. If we asked patients today, we are all here patients, we endorse this, undoubtedly. But if you ask providers, most definitely, because it is their core mission, such incentive that this transition will be made easier is, in my opinion, very much linked to the payer. Well, here, patient's interest, as we said, comes first, but not just one. There are several patients, also associates, stakeholders, whether to pay for 1 million treatment per capita, etc. Many questions are here. We open Pandora's box. Direct providers, when we spoke about the mission, we seem to forget about them. They are being criticized for not doing a good job. You don't work hard enough. People start leaving the system. They are not deciding to study medicine or pursue nursing. The payer has all of a sudden a lot of money, but nobody to provide these services. Here, direct providers, doctors, nurses are not involved sufficiently. Maybe they even know best how certain things should be overhauled or managed, but they are not given an opportunity so that their ideas would be translated into day-to-day life. The way I see it, when I interact in my hospital, here we have a great motivation potential, but at one point the interest is lost. And maybe you, Anka? Well, as the payer, again, we wonder about the role of the payer within the system and what role we should have. Our institute is not an insurance company per se compared to other commercial insurance companies. It is very important that it doesn't have powers to define rights, also based on data, but it could, to define what is the right in the basket of benefits, what is not. And also we don't set the rules for paying. Unless we have the system of agreement and legislation that is in place, we don't have enough elbow room where we can determine prices and also put them into practice. Although we use cost analysis, follow all the rules, etc. If partners disagree to accept this price, then it is changed. It is a complex and great system, and it will be difficult to overhaul it. If I may, when we observe public healthcare system, if you read articles, doctors don't understand why we speak about different costing methods. But for healthcare, we don't want to fund it in a way to only recover costs, because we need to have some efficiency gains as well. Paying models that we're developing also serve the same function, to have calculating costs and to also include incentives, so that incentives about efficiency was included as well. As for payment by bundles, in itself leads to incentives for providers. They need to cooperate more. Here I see the role of the payer to be decisive, not only to support what happens naturally. If I may, yes, DRGs, if they are updated, then okay, if they show the current state of affairs when it comes to costs, but for years, maybe even a decade, they are outdated, they are frozen, and at the management level of a hospital, we see that for some DRGs we have losses, for some we have profits, and we need to strike the balance if we have an option to do so. Some providers accept this, some don't. The real functionality of DRG is not that, but the skill and management style of the hospital leadership. Maybe we will take one or two questions from the audience, and then the last round. Two ladies. Biserka will go first. Hello. Really thank you. An excellent conference, lectures, and also co-authors. But Dorian, let me go back to your question, how to implement this as fast as possible. Who is responsible in Slovenia? I believe that only if we are aided by patients. As a patient, I don't want to know whether it will be my turn for the procedure and how long I will have to wait, but what health outcomes can be expected. If the voice of patients is not heard here, given 25-year experience about the implementation of quality and safety, we will not get far. We will not make a breakthrough. And secondly, the payers should be interested in addition to patients, because they should demand certain health outcomes based on which they will pay. And of course, Dr. Rozman, you are right. Providers will have to work hard, and everybody will work hard in order for patients to come to the hospital. We, patients, want to know not only when will be our turn, when we will have the procedure, but especially what will be our health outcome. First, we will have 3 questions, then you will respond. And Hans also wanted to say something. Tanja Španić, Europa Dona. I will continue. Well, Biserka actually finished. I have the whole list. I have chemo brain, which is why I will read. This is my excuse. I keep saying for 10 years, patient-centered approach. Well, at the same table is a better translation in order to have shared decision-making. Patient-centered doesn't mean that patient is in the center, but towards patient.
Maybe add something to this, or even Nicola also, what we've briefly discussed during the lunch. Grem nazaj v slovenščino.
I will switch back to the Slovenian, says the speaker. Then accessibility. We speak about one step ahead, but we are missing a lot to get there, to arrive at value-based healthcare. Biserka also mentioned, I don't want to know only when I will be treated, how long I will have to wait, but also about health outcomes. We are familiar with accreditation. I'm familiar with breast cancer. We should not reinvent the wheel. Everything is out there. Various quality indicators and probably we can introduce them quite fast. We can have small-scale models first, but it seems there is no interest from all stakeholders. Let me go back to Biserka. Hans nicely introduced bottom-down systems and everything bottom up and bottom down. Here we will have to meet somewhere in the middle. I believe that we have been talking quite a while, but no shifts have been made. And maybe patients' representatives are the ones who speak a lot about this, our healthcare system. Dr. Rosman has mentioned this already, DRGs. If you are a patient, you don't know what this is all about. When you start dealing with advocacy, you see that you are just a number, a code with C50 diagnosis, and it follows you from the day you got the diagnosis till the day you die if you are a breast cancer patient. We should change this perception among doctors, the payer, and unless we do that, we won't have this value-based healthcare. And just briefly, at the end, I just returned from a conference on European breast cancer. The whole session was on patient-reported outcomes, and we came to the conclusion similar to your survey. Experts are not even familiar with it. There is a lack of understanding when it comes to patient-reported outcome. It is the only unit that user reports patient-centric outcome. Everybody can report, medical staff, caregiver, or a patient. What are PREMs? Experience that doesn't have an impact on the outcome. Probably we should go 10 steps back and start at the faculty. Dorian, I'm here looking at you. We can lobby somewhat with education providers here. We will have to do it at several levels, but to start at the same time. I believe that we have plenty of experts. We also have the will. And I will repeat what I keep saying. We need action in order to move. And I will end here. Hans?
Thank you very much. Just some minor remarks there. One thing, if we have a town in Sweden called Gothenburg, it's also Little London, with the irony, and they usually say that the patient is at the center, or in the center, not at the hospital.
I will explain you later why you translate it. Based on my experience.
In the city center and not at the hospital. That's sort of the traditional. But I see when we talk about reimbursement models and governance tools and these things, I think it's very important that we don't confuse analytical tools for the ones that we use in order to get behavior out of the organizations. Because the analytical tools are and should be quite complex and complicated, which means that we should use people that are familiar to those kind of tools. When you run by DRG, for instance, you mix them in a very confused setting and no one really uses them, only as weapons. And then when you code, it depends on how much you pay for each DRG, and then you have specific coders. I followed the guys who introduced DRG in Sweden in the early 90s, and the first thing they did was advise the ministry and the local regions. And the second thing, which was the big business, was going out to the real healthcare providers and learning them how to fill in the system so they got their money. So it's a very good business idea, but it's, as a managerial idea, it actually sucks. So and that's a plea to all the doctors. Listen to people who actually know management, who knows how organization works. And that's not the medical knowledge, it's a societal knowledge. We have to work together, because I wouldn't interfere in changing a heart or working with cardiology, but I can do some things in order to get the governance system in place so that you really have the freedom to do what you want without being bothered all the time when you're actually doing it. So I think we need different competences. We have to accept and respect that we need different competences in this.
Hans, thank you for... yeah, another one.
know we're very short of time, but listening very carefully to the two of you, what strikes me, and this is what happens, I think, in other countries and also at European level, is the notion of patient leaders, patient organisations as conveners. So obviously patients at the centre, but also bringing together the different players and having a patient-oriented discussion on moving forward. That was just my reflection from the comments I heard. Thank you.
Thank you for your thoughts. Might be later on, but you know, I cannot. I just have to reply. So it's. I'm also for patient in center. You know why? Because in Slovenia, you can even publish in media. In Slovenia, patient does not exist. It's a problem which does not exist. This, for me, this is why you have to put the patient center. At least we'll start to think about patient. We are not yet prepared for patient-centered system, which will be in Slovenian osredotočeni na pacijenta. Mi žal še nismo. This is why we are in a period of transition. So first we'll put the patient in the center, and then we will start thinking about patient. So just like excuse, but I'm delighted that they like Slovenian language so as they did. So just we are well aware about, and especially about DRG. I was there. DRG is as it is, but it's a model. This is why I'm counting on this new model to make a next step. In healthcare system, we have to work on evolution. We cannot stop. DG has positive and negative parts. Value-based healthcare has a positive parts, have negative part. It might be that we will find it out that it solves only some problems, but probably it should be considered and implemented in the system. So we are believers. So now we'll have to conclude. Najprej smo postavili izhodišča.
First we set the starting point, then I shut the light, and then we woke up in the system. But before turning off the light, tell me what should be done before we turn off the light so that this model will be in Slovenia one day. Which is the most critical thing that should be done. You said a lot that we need to motivate patients. The role of the payer matters. The ministry has a role to play as well, etc. What you would offer as one key principle before turning off the light, before waking up to the new world, to the new reality of value-based healthcare? First, we need to find the conductor to bring together partial interests, because we are all doing something, but we lack somebody. I think it is a pity, because many efforts are wasted, because everybody is doing something individually, fragmentedly, and we don't progress. And this is of key importance. We have a lot of knowledge, we have plenty of experience. However, we don't know how to pull resources together. We are all doing it, but we pull in the different direction. I believe that there are plenty of challenges here. The whole system is as it is, but now we should overhaul it. It's high time. First, to reform the planned economy system as we have it now, to set up the system where the money will follow the patient wherever he or she goes, whichever provider they choose, and to change the model of how to manage healthcare establishments. Our guidelines, well, we proposed where we should start with the implementation, which specialties to include, the areas were deliberate, reflected upon. We should select one or two and do it. Then, providers which are involved should be supported. They cannot do it on their own. We talked about that today. Good practice examples that follow will motivate people in order to expand this to other parts of the healthcare system. We only need to start. I am the last, and I have to agree with everything that has been said. I will be a philosopher maybe in the end. Above all, as we've already learned in our guidelines, we have many good things in our system, and maybe we should be proud about this, and also to say that we have knowledge, We have basic IT system, which is not bad. Of course, it has to be upgraded, but it is not so bad, mind you. And to be more positive, as Aleš has just mentioned, we just keep saying about bad things and then nobody will study medicine. And we should be positive and focus on change. Open-minded is the English term. As for Slovenia, let's be open our heads, and let's not immediately oppose the new concept. Dear participants of our round table, dear listeners, all the participants, esteemed guests, I do hope that we will leave and we will invite the patient to the table, which should be a round table, not somewhere at the edge, to sit with us, to improve the healthcare system, to get rid of all the garbage, all unnecessary services, to open our doors widely to innovative approaches that make our quality better, extend high-quality life, years in life, that we will have satisfied providers, a happy payer, which actively purchases requisite services, and overjoyous regulator promoting the healthcare system in the wider European concept. What should be done? To go home and start tomorrow. And now I'll give the floor to Martina.
Hvala lepa.
Thank you very much. We heard many thoughts, but we are now slowly into the future. We should start and conclude at 2 o'clock to hear final thoughts, which will be heard now, and it is already 2:45. Without turning off the light, we are at least half an hour ahead. Anyhow, now we will hear final thoughts. Secretary General of the Forum, which is our host, Master of Science, Barbara Stegel. Thank you. I won't take too much of your time, but I won't well, you can't take away the privilege to thank all the participants. Really, thank you, a sincere thank you for helping us, for interlacing our threads when it comes to value-based healthcare. I would like to thank you for trying that these threads are summarized, that they are defined, that now we will have our future pattern based on our development-based questions, which are plenty. We were all wondering what in fact constitutes value, what it means to us, to what do we attribute it to, how do we perceive it, and how we determine it when it comes to the healthcare sector or the healthcare system. I believe that the entire debate today, one thing was clear. This value that should focus on the key role, the key actor, the patient, should be determined jointly. This is in fact the key message, the key takeaway. If this value is not determined, if we don't measure it continuously, then consequently we cannot achieve it. And in this way, we inevitably create opportunity costs. Normally, nobody measures them. They can be enormous. We don't just speak about monetary value. Above all, we spoke about health outcomes for all of us when and if we need healthcare. The topic of today's conference, value-based healthcare, in fact, was met with some critical remarks by our participants. They say it is a long-term project, that we are trying, when it comes to value-based healthcare, define the roof, while many still doubt the stability of its foundations. Yes, indeed, we are guilty of that. However, our basic mission is innovation. And these innovations are enshrined in the future. We need to define it, plan it, and also put it into practice. Also, our stakeholders who are here today expect, above all, that we bring to the market new innovative medications, new treatment procedures, not just something, but those solutions that are able to demonstrate, prove its value, added value and progress when it comes to delivering care to every individual patient. And we need that. Of course, we wish and we want to help when building the healthcare system in all its stages. However, an ambition to be better is something that we don't want to give up on together, but also not individually. I'm a very proud citizen of the most beautiful country in the world, Slovenia, which is not only my native land, but also my chosen land. Every day, I have been noticing this relentless global competition in the area of development, also when it comes to healthcare. Simply, we cannot afford to lag behind. In this competition of value innovations, if we measure it and monitor its impact correctly, then they create its own room for further development. For that reason, I think it is only correct that today's day was dedicated to what is our desired future. Dorian has turned off the light, but then he turned it on again. Allegedly, there had a sundial in Rome, and it said, it was written that they only count happy hours and sunny hours and sunny days, probably because of technological imperfection. However, I still believe that those hours that we spend today here in our debate can also be regarded as sunny days and sunny hours. I do hope that we will co-create them together a lot more in the future. By way of conclusion, I would like to call upon all of us. Let us cooperate, let us contribute, let us listen. In doing so, let me just highlight one thing, an absolute value for all of us living on Earth. That is time. Thank you very much. Thank you. Before we really turn off the light, you are invited to take use of this precious time to spend some time with us. There we will open the doors again for socializing, for networking. Bravely, let's take steps on our own paths when leaving our room. This bravery, decisiveness, and one conductor, we will get him or her. Good luck, Slovenia.
The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white.